I'll meet you officially after. All right. Good afternoon. We're here today for a joint board superintendent's insurance advisory committee meeting. Pam, roll call, please.
Ms. Belter?
Present.
Ms. Campbell?
She's here. She just went take a break.
Ms. Deskovich? Here. Ms. McDougall?
Here.
And Mr. Susan?
Here.
Please stand for the Pledge of Allegiance. I pledge allegiance
to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
All right, at this time I will turn the meeting over to Mark Langdorf, Director of Risk Management.
Well, great. It's great to have you all here. I know there's a lot of faces that people don't know, so do you mind if we go around the table and introduce ourselves?
Before we do, can I just take a personal privilege first?
Absolutely, sir.
Good afternoon. Mark Mullins, Superintendent, just in case I haven't had the privilege of meeting you yet. I'd like to introduce first our new CFO, Chief Financial Officer, Ms. Cindy Lisinski. She is excited to be joining the team. She's day 2. We obviously so she is happy to answer all of your questions that you may have today. We've fully briefed and prepared her. No, she's hit the ground running, no doubt. But Ms. Lisinski, it's great to have you, and welcome to Superintendent's Insurance Advisory Committee, and we'll bring you up to speed as quickly as we can.
Glad to be here. Thank you.
Mr. Langdorf, one moment. Ms. Escobar, would you just make sure that it reflects that Ms. Campbell has joined us? Okay.
Present.
All right, back to you, Mr. Langdorf.
Would you like to start? Lisa, would you like to start?
Oh, Lisa Schmidt, Manager, Employee Benefits.
Manila from Marshall, Principal, Tropical.
Leslie Lauder, representing Support Staff Local 1010.
I'm Amy Williams from Space Coast, representing BFT.
Jeff Bailey, representing BFT from Central.
Paul Gibbs, General Counsel.
Tina Deskovich, School Board District 3.
Don Butterfield, Tina's appointee.
Chris McAlpin, Misty Belford's appointee.
Misty Belford, School Board.
Mark Mullins, Superintendent.
I'm Mark Langdorf, Director of Employee Benefits and Risk Management.
And Cindy Lisinski, CFO.
Matt Susan, School Board Member.
Dominic Loretta, appointee for Matt Susan.
Katie Campbell, School Board Member.
Sheila Gaylor with Bill and Sheila Gaylor Insurance, and I am Katie's appointment.
Cheryl McDougall, School Board Member.
All right, terrific. I know we have a big group here, so we'll get to know each other well over the next couple hours. I do just a little bit of business for the Siac team, and that really has to do with the minutes from the January meeting. I sent those out to everyone. Have you had a chance to review them? Does anyone wish to make any changes to those minutes? Are they acceptable to be approved?
Acceptable.
I need a first and a second.
So moved.
By Amy Williams, second by Sheila. All in favor, say aye.
Aye.
All right. Now we'll move on to the agenda, which is really about a historical view first by Jonathan Anderson. He's with AM.
Yep, thank you. Thank you, Mark, board members. Again, my name is Jonathan Anderson. I'm the Vice President of Aon's public sector team. We represent about 28 different public school systems throughout the state of Florida. And you're going to hear from myself as well as our team member that supports the district. And Phil DiNucci is the first gentleman here. He's the pharmacy expert. He's worked in the industry for over 28 years, worked with Express Scripts and a lot of other PBMs. Amanda Brooke Cross is your actuary. She's down in Vero Beach. She's been with the organization for over 10 years, works with a lot of the school districts throughout the state of Florida and the Department of Insurance on the 11208 filings. Paul Booten is a senior vice president with our public sector group. He works on groups throughout the state of Florida. And then Nadia Elmenayer is your analyst. She's the one who does all the work and keeps us all straight. That's the one you really want to be nice to. So again, thank you for the time. Aon appreciates the opportunity. We put together a presentation along with Mark and his team to make sure that we addressed really a historical view of what the district has gone through since actually 2011. And I hope everybody had a chance to receive the information, have a chance to review it. And really the focus on time and trying to get to solutions. I just want to make sure I hit this at a high level. Be happy to go into it more detail if you need me to. But I want to make sure I hit it at a high level so we can get to really some solution sets by the end of the meeting. Does that sound good? Okay, fantastic. So as you have here in your information here, the summary of recent plan management initiatives, we worked with Mark and Lisa and the team and went back over the history and really identified some of the areas as far as the year particular changes occurred, board contribution, plan design, and actually the vendor that was represented. So 2011 to 13, I'm just again sharing with you that over these particular 3 years that the board had contributed about $10.6 million to the fund of the 11208 statutory requirements required by the state of Florida to have 60 days of claims in reserve in order to meet that statute. So that's a big, important, I'd say, compliance number, and we'll go through more of that information as we move through the next couple pages. But as those particular contributions were made, there was movement to a PPO plan design, copay changes, and you've been with Cigna since that 2011 period. When you look into 2014, there was another cash infusion of about $2.15 million. That's where some additional benefit designs were added as far as a deductible, and Cigna again was the carrier of choice. 2014, there were some actions that were actually implemented where it included some wellness introductions as well as some additional cost sharing, and again some changes that helped create that surplus. Oh, I'm sorry, I am multiplying. Let's see.
The down arrow should be the...
Yeah, that's not working for us. Is there a... There we go. All right. There you go. Okay. So, as I mentioned before, there was some surplus in that 15-16 time period. We also there was a release of a 5-year contract that was secured in 2016. And then at that point in time, the 17 to 18, they were starting to see some combined deficits occurring. Marathon, the clinic was implemented during that time period of 17-18. And then as we look at 19 and 20, again, 17, 18, there weren't any changes in the rates or benefits. We move into 19, again, no changes in the rates, and there was a deficit of about $4.8 million. There were some plan design changes. You were still with Cigna, but during the 2019 period, Aon came on board, and that's when we actually went to RFP. We took the RFP out to bid, and as you can see, basically the RFP resulted in about $4.3 million of savings for this year, and about $7.4 million over the 3-year period. Again, quality results that came out of that. As I talk about projections, and Amanda Brooke Cross talks about projections going forward, those are all built into the projections. these particular savings, so we're starting at a base. Okay? Any questions on the summary? Pretty self-explanatory? Perfect. We're just setting it up. The next page, if you look at the contribution and expenses. So what we did on this page is we started to really understand the board contribution, the employee contribution, the total premiums that were being charged, and then what your expenses were looking like. And so as we look through this particular page, you see some movement relative to the premiums moving up, but they flatlined kind of right at this point in time, which would be your 17, kind of right about here, your 15, 16, 17, 18, 19 period, and those premiums have flatlined. In the meantime, when the claims have started to increase, and we're getting to a point now where there's a deficit. And we've talked about the deficit multiple times in the Siac meeting. This is just a little bit more of a visual that will give you the breakdown from these particular 4 components. Okay, does that help? Perfect. If we go to the next page, this is again very positive, I would say, for the school district from a standpoint of Aon and Amanda Brooke Cross. We do our actuarial trends, and we come up with an annual trend. We basically baseline our trend, and we look at the numbers as far as what it would look like going forward each year with our trends built in. As you can see, going back to 2010, it's really about 2013 that your claims have actually beat Aon's trend throughout the years. And so multiple components to that. And we're going to talk about the pharmacy cost, medical cost, where you benchmark, etc. But again, versus the national numbers that we do with trend, it's a good statement that this includes all of your costs relative to, not all of them, but the medical, the RX, and your clinic costs. Okay? So that's a positive page there. We talked about the 11208 and the filing, and relative to where you have been and where you are headed at this point in time. Again, going back to 2010, there was a deficit in this particular time period. Mark, I don't know if you wanted to make any comments relative to this time frame.
Well, that was before I came on.
Just to clarify.
Let's just be clear.
Just get that out there.
But we were getting cash infusions, but for that long period of time. And I even though I was still working for the district, I wasn't over the benefit program. We had people that were on our Siac committee at that time, but it's my understanding that we continued to have deficits. The state did allow us during that time period to use the district's rainy day fund to kind of say that it's okay to continue on. But the last year, which was 2014, they wrote a letter, and I have a copy of that letter that basically said, if you can't shore up your fund, you can no longer continue to be self-insured. So that's where the change that I see took place in the 2014 time period, where we had to make some major changes, and we collapsed plans. I think we had 3 different health plans at that point. We collapsed it into one plan. There was increases in premiums for both employee as well as the school district, and plan design changes that took place in 14.
And so going back to those comments, as you can see, the adjustments were made back at this particular period. Fund balance created a surplus, and the prior areas we showed that there weren't any rate increases, there weren't any benefit designs, etc. Nadia is going to show you a little bit later on that your PPO plan design is the best out of the benchmarking that we do have in this particular packet. Very rich plan. And as well as you have access to clinics. So really, there's a lot of positive things to say in this direction. However, today, where we would like guidance from Aon is just make sure that we get agreement on let's figure out how to solve the problem. So we've got some ideas to solve it. We're going to need some input and some dialogue around that, because I think that's what you want us to help you do.
Can I interject here? When you're asking us to solve the problem, I think we need to decide what solving the problem means. I mean, does solving the problem mean getting through the next filing in June, or does solving the problem mean we'll never be in this position again? You know, so I think that needs to be cleared up.
I think that's a great point, and I would look for the group to help us clarify what that is. Because all we want to do today is, in a lot of areas, is present the facts of, and we thought the history would be important to share that as far as what has occurred, and then really kind of try to move forward based on additional data. But I think that's a good point, and you know, that's why we're here. Okay, so I just wanted to lay that out as far as I thought that was important before you move into really starting to take a look at Cigna's claims information as well as Marathon, and then we'll come back and we will talk about you know, more of the financial overview and the benchmarking. All right. So I'm going to turn it over to Brian, McNeil, and Kelly to go over the Cigna data that you have in front of you. Thank you.
Can I ask a question? So if we do the numbers of minutes total that are in the presentation, it leaves for 27 minutes of conversation. Are we willing to reduce the amount of time that it takes to present or extend the amount of time on the back end? Right now as we speak, we have 22 minutes to discuss past the presentations. I think this is a major issue and I'd like to discuss it more, but the presentations are eating up the majority of the time. So I just wanted to see what the direction of individuals would like to carry, whether that's extending the time of the meeting or reducing the amount of time for the presentations, just so we have notes. That's all.
Board members?
I want to make a comment also. I've been in management of healthcare for 11 years in my past life, and I've done counseling and presentations, and I've seen PowerPoints, but I have never seen a PowerPoint that's 72 pages. And I'm concerned that it's a 72-page PowerPoint. So I was expecting pretty much just the meat, not everything that is 72 pages to go through. So I'm hoping, but I agree with Mr. Sisson, that we can pare this down to make this what is the most important. What do you think we definitely need to see to make some good education of where are we going from here? But 72 pages, I don't think I've ever attended anything that's at 72-page PowerPoint.
Madam Chair, my intent was
Welcome to Siac.
The amount of value of the presentation, because I think there's a lot of value in understanding holistically the plan. My first recommendation would be to extend the meeting. My second one would be to reduce it, because there's a lot of information in here. I agree with you. I just didn't want, if they were going to make their presentations, to reduce them all of a sudden and get to a point. That's all.
My only concern, Mr. Susan, and I agree with you, my only concern is we have a whole lot of people sitting around this table that we would literally have to go and ask every single person if they are able to stay later to extend the meeting. I think that probably the most prudent thing for us to do is to do our best to stay on track. You all, anyone who's presenting, if you could just be cognizant of time and absolutely give us the highlights. And see if we can build in some additional time for discussion once the presentation is wrapped up. I think that would probably be the best option for us. We can always have additional follow-up conversation with Dr. Mullins.
But not as a group.
Right.
I'll just say this, Brian, can you just focus on the highlights? Kelly, do the same. Dave, with Marathon, please just focus on the highlights and move this as quickly as we possibly can. This is just a summary between 2018-19 that Cigna will give, and you've not seen a presentation from Marathon Health, so they will focus on those highlights and be done quicker than the time limit is.
So I think it's important to do a time check, just so you know it's 12:18. The agenda portion of what I've allowed you to go till 12:45. So you have less than the 35 minutes you had scheduled, and you need to stick to that time.
Yeah, we'll be closing that.
And can I ask a question? I'm sorry, I walked in late. I apologize. I'm a little confused about the structure of this meeting. Is this a Siac meeting or is this a board meeting?
That's a good question.
I see that Ms. Belford seems to be running the meeting. I'm just confused as to the structure of the meeting.
It's a joint board meeting and SIAC meeting.
in which usually when they're joint, the chair of the school board runs.
Okay.
So can side members have comments like
Of course.
normal?
Of course.
Okay, good afternoon. I'm Brian McNeil with Cigna Healthcare, and this is Kelly Monzello with PharmD with Cigna. And as Mark said, when we go through the Cigna reports, the base period will be January through December of 18, and the current period will be January through December of 19. So with that, just real quickly, if you look in this bottom left-hand side here, the navy blue section, really just your membership has decreased slightly from a year ago. If you look in the middle section there in the cost trend area, it's looking really good from my perspective. When you take both the medical and pharmacy together combined on a PM basis, you're only up 4.4% from where we were in 2018. I think Jonathan alluded to the fact you're running better than trend, and for Cigna, medical trend would be about 7.5% annually. So to come in at 4.4% from my perspective, it's really good. Looking at your actual catastrophic claimants, you did have a slight increase in the number of catastrophic claimants year over year. But your cost in total has only gone up about 4.5% for both medical and pharmacy combined. By the way, when we look at this plan spend of $72 million, that's both employer and employee costs combined, and does not include the discounts or the rebates that you got back on the pharmacy side of about $2 million. Okay? On the right-hand side, this is showing that about 42% of your membership has a chronic condition. They represent about 75% of your total cost. About 60% of your population are engaged in the Cigna programs. If you look on the right-hand side of that, 39% is the norm for other school boards across Florida. So your engagement for your employees is higher in the programs than what we typically see. The preventive care utilization is slightly below the norm, but it's up a little bit from a year ago. And wellness completion visits are as well. Health assessment completions went down a little bit, but about much higher than the Cigna norm. So I think that all looks very good for you. Now, on the pharmacy component, 91% generic utilization is excellent from what I see from other clients.
And if you want, all that information is on subsequent slides, so if you
Yeah.
need the time, we can.
Yeah. Okay. Looking at your population, about 52% of your population is over the age of 40, upper right-hand side here. The average age is about 37 and a half years old. They're almost about 49 years old at the age of the teachers, all the employees rather, and you're about 63% female and 37% male. And no surprise, the older we get, the more expensive we are. So if you look at the middle section there, and also excluding catastrophics, the most expensive age band is 65 plus. That's up about 7.3% from last year. Although excluding the catastrophics, that age band went down about 12% from a year ago. It's still the most expensive on average. Okay, looking at spend by relationship, on the upper right-hand side, you can see the spouses is what costs the most at $728, although it's down 10% from a year ago. And that's typical with all of my clients, not just school boards, but typically the spouses tend to cost the most money. And if you look at excluding the catastrophics, they're also the most expensive as well, at $425, and they're up about 5% from a year ago, and slightly higher than the school board norm of $405, just to kind of give you a level set of how you compare to other school boards that Cigna has across the state. Looking at what's driving your trend, if you look at the bar graph here, you can see that the catastrophics is driving the trend by 1.4% of your trend, and the physicians is about 1.2%. And on the upper right-hand side, overall for the non-catastrophics, you're up 5.7% year over year, which is excellent compared to what typical trend is. If you include all the other catastrophic costs, you're at 5.5%. The member cost share is up 2.2%. So what the members paid out of pocket went up only 2% year over year from 2018 to 2019. When you combine all of that, the net to the school board is a 6% increase. But when you factor in the fact that pharmacy only went up 0.5%, your total is about a 4.4% increase, which is well below trend. Looking at the pharmacy then?
Yeah, so as Brian mentioned, so pharmacy trend is 0.5%. And again, that's gross trend, so that's employer paid, employee paid, and that does not back out any of the rebates that have been received back. So if we actually factor in the rebates, the pharmacy trend is actually a negative, about negative 3.7%. So by any measure, a really good result from a pharmacy perspective year over year. So the little graph on the left-hand upper side does do the breakout between cost share versus the paid amount, which is the employer paid amount, and then again the overall increase of 0.5. So we look at the trend impact. Inflation had a 3.1% impact on that trend. drug mix of 5.9%. So even though we see in the green box all the way to the right that there's a very nice increase in generic dispensing rate of almost 2% year over year, which is fantastic, and the generic dispensing rate is now above norm. We are also seeing increase in specialty utilization at a very high cost, as well as some classes that typically had pretty low cost in terms of low generic utilization, diabetes, for instance, which is 27% of your non-specialty drug spend, which it is the biggest bucket. Some newer, more novel therapies in those categories, but at high cost, driving up that overall cost of the drug mix. And then from a utilization perspective, we see an 8.5% decrease. Some of that is related to the formulary change that we made last year. So some of the classes that are over the counter are no longer running through the plan, so we see a decrease in prescriptions there. If you have your clinic is being utilized more and more medicines coming out of there, so we see a decrease there from utilization. And the last thing on this slide is the box on the bottom right, which is your specialty pharmacy. So it breaks out pharmacy and going to the specialty pharmacy through the pharmacy benefit, which is anything that's self-administered by the patient. And then on the medical side, medications that the provider has to actually administer, that's going to be running through the medical benefit, but it's drug spend, but through the medical benefit especially. So you can see that from a pharmacy specialty perspective, the specialty drug trend was 4.2%. On the medical side, it was 10.6%. The overall specialty trend is on the next slide.
I have a question.
I'm
Two
sorry.
slides back, please. Because we keep talking about cost share, it's gone up 2.2% medical. Is that premiums? Is that out of pocket for employees? I don't understand what the definition of what is cost share.
That's what they pay when they go see the physician.
So it's out of
Pocket.
pocket?
They're actually out of pocket costs, on average, yeah.
Thank you.
And so they're averaging, what, $56 PMPM, and the school board knows $51.
Thank you.
Okay, looking at your catastrophics real quickly, we did mention you had an increase in the total number of catastrophic utilizers. Catastrophic, from Cigna's perspective, is anyone who has over $100,000 in paid claims. You can see last year you paid out about $112,000 on average per high claimant. This year it's about $114,000. We're up a little bit from a year ago, but the norm for other school boards is about $139,000. And on the upper right-hand side, you can see that the catastrophics in total are only up 4% from a year ago, the non-catastrophics 4.5%, and then when we manage the two together, it's 4.4%. Okay?
So this is looking specifically at specialty, and the upper right-hand side here is going to be a little bit repetitive of what we just saw. So the pharmacy specialty trend through this pharmacy benefit, and then the medical. But the medical is broken out here by site of administration. So we know that it's more expensive when the infusions and injections are being done at a hospital-type center. And that's the second bucket here. And it's much more affordable to be done in the healthcare provider's office or home infusion. So your medical spend actually went down at those sites of care that we prefer they not go to. And so that's through our steerage within our prior authorization process, making sure that numbers are going to the lowest site of care that's clinically appropriate. And this is one of the best results I have seen in my book in terms of the amount of spend going through those sites. In terms of the medical specialty spend. So in aggregate, when we look across the pharmacy benefit and the medical benefit, the specialty trend is 6.5%. And then as we mentioned, the non-specialty actually was down 1.5%. And the pie charts at the bottom are just showing you the types of conditions that are going through the different benefits. So pharmacy benefit, $5.7 million on specialty spend, and these are the conditions by far. Inflammatory conditions like the rheumatoid arthritis, psoriasis, and Crohn's are the biggest bucket. And then from a medical perspective, cancer is the biggest bucket in terms of the drugs going to the medical benefit for specialty.
Kelly, what is the percent of specialty that's generic versus brand that you don't have any, option for?
What do you mean you don't have any option for?
That doesn't have a generic.
I don't think I have that off the top of my head. We can.
Okay.
Yeah.
Can you explain? Yeah, what was the question again, just so I understand?
How much of there's a lot of specialty drugs that have gone generic. So they're generic, so they're less expensive. So just kind of wondering, this is the biggest, cost driver of pharmacy. So wondering what percent of specialty now is generic versus brand that's still new under patent.
Yeah, I would say you're right. More generics are definitely coming to market for specialty. It's still an area that doesn't have a lot of generic opportunity, but it's growing. And the biosimilars, which is a little bit different than true generic, but that's another aspect as well.
I guess a better question would be, what specialty drugs are we using that there's a generic option also too, that we may not be utilizing? Is there any of that going on?
We could do an analysis. I mean, we do so we manage specialty drugs across benefits. and we're driving to a lowest net cost. So when, typically our standards are when a generic becomes available for a specialty or any medication, the branded medication moves to either a non-preferred tier or completely off formulary. Now, I will say that in some instances, so take a cancer patient that potentially is on a medication, stable on a medication, and the generic comes available. We may not kick that person off of their current therapy, but for any new starts, we would guide to a generic. So I don't have the statistics from our book in terms of what percentage. I can certainly do an ad hoc report as a follow-up in terms of percent of specialty that is generic versus non, but in terms of what I can do is take a look at multi-source specialty medications and see what kind of utilization there. But
when a person makes a request or they go to have a pill dispensed or a script, you guys then identify that and try to drive them to the lowest cost option available.
Correct.
And is that always going to be Cigna home delivery, or are you guys trying to drive them to other lower cost options?
So it depends on where the medication, so if the medication is a specialty medication that's going through the pharmacy benefit, our plan design is to have it go through a specialty pharmacy, which is Cigna Specialty Pharmacy. We know that there's better outcomes in those settings. We know that there's better adherence, less ER visits, things like that are basically better outcomes when we have it managed. Having been a pharmacist at a Walgreens that did 700 prescriptions a day, 30 flu shots, running from end to end of the store, I quite frankly didn't have the time to appropriately manage and counsel those patients that came in with something as simple as an Enbrel or a Humira. It just is reality. I'm not saying those pharmacists aren't capable of doing it. It's just a matter of how it is. So we know that something like a Credo that has specialized therapeutic resource centers with nurses and pharmacists that are specializing in that condition, managing that specialty patient as a whole results in better outcomes and overall lower medical costs by making sure adherence is there and best outcomes. If we're talking about a medical specialty drug, we are agnostic in terms of where that medication comes from. What I mean is that we're not forcing it to go through a particular channel. A lot of times, quite honestly, a physician might be able to use their cost of trade discount to get a better price. And in those cases, we will work to try to get the lowest cost in terms of where the drug is coming from, as well as where the drug is being administered. So if the patient is getting a drug at a hospital center but can be moved to a provider's office, we work to do that. In fact, I think there was $50,000 in savings by moving one patient last year from the district to a provider's office instead of a hospital type of treatment.
And if I could just add to that, though, if you show up at the pharmacy and ask for a prescription and there's a lower cost generic available, the pharmacist will offer that to you, and if the actual cost of the medication, the generic, is less than your copay, you get the lesser of. So we have that logic built in for our tools as well. So we're always steering to the lowest net cost for the patient.
And one of the plan changes that was actually put in for 2019 was mandatory generic. So when a generic is available, it's mandatory that the generic be utilized by the member. If the member, and even if the provider says, no, it has to be the brand, they can get that, but there's differential where they pay the difference between the brand and the generic cost.
Where my concern is that you guys would steer them towards Cigna home delivery, which would be a higher cost option than the one that they previously had.
I don't know that we steer to home delivery.
Well, we have specialty exclusive specialty, again, for the reasons that I stated.
My Cigna app, if you put in whatever medication you're looking for, it'll give you all the options, whether home delivery is fast or the lowest cost price, if you will, or the CVS or Publix, what have you. So it'll map you to that location, so the app tells you what's the lowest cost.
Right.
But for specialty medications, you can't get that on the second refill anywhere except for Cigna specialty.
Right, that's our plan design, correct. And that's very industry standard.
Well, that's a concern that I had based upon the fact that option is more expensive than the other options that are available to the individual outlet. That was the concern, is that we are captivating an entire group of people towards specialty drugs that are more expensive than what is other options are available.
I think it's drug specific.
Yeah, it's drug specific.
So
there are several
there are
drugs
going to be some
Cigna
where we might be more expensive than potentially a pharmacy out there. So I think that, there are certain pharmacies that may have potentially a much lower cost. For instance, if you look at our home delivery, we don't have a zero cost metformin, but Publix does. There's reasons why pharmacies choose to price where they do. So there may be a pharmacy that you can find that particular medication at a lower cost. But in aggregate, we have a contract in place that requires that we meet a certain discount on specialty. And regardless of whether it's gotten, at Cigna home delivery or in the retail setting, in aggregate, that discount needs to be adhered to. And then if it's not, we should.
Do you guys set the rates at each one of the pharmacies prior to. So you know what the cost of the drugs are supposed to be prior to that person going there, correct? Cigna sets the rates and negotiates the rates at the local pharmacy.
At an aggregate
4-hour
level.
plan.
And an aggregate level, yeah, each drug. So one drug might be AWP minus 80% at one location, and down the street might be AWP minus 75% or AWP minus 90%. But to Kelly's point, at the end of the year, in aggregate, we're going to guarantee you AWP minus, I don't know if it's 80% or 82%, whatever.
Right, I mean, we contract with a chain,
Right.
so if we have a contract with Walgreens to be a certain price, but it's in aggregate. So one pharmacy could be a brand new start, and they were trying to drive some, business there. It may be a lower cost than 3 miles away. But in aggregate, we have a contract with them for a certain pricing.
And we true that up at the end of the year, and I think we actually send over to Bonnie and to Mark, what the final results are, and if we owe money to Brevard Schools, we pay that. I think it was $140,000 last year to make sure that we met our obligation to you at a certain.
Is that AWP minus part of our contract, and is there a percentage out there? So like we have a contract with you, and it's AWP minus a certain amount for each one of the pharmacies, or
No, it just in total for like brand name and generic, and correct.
So to be clear, the reimbursement at different chains or different stores are different?
Correct, yeah. Even from the same chain 3 miles away is different.
So it pays to shop.
Right.
So, from the employee perspective, if they do not want to go on the mail order, even though you all have identified that's where they should go, even if the cost is higher on that particular medication, can the employee choose to go to the local pharmacy
Yeah, I think your
instead?
mail order utilization is less than 4%.
So specialty, the current plan design is that member is required to get their medication through the specialty pharmacy for the specialty medication.
So they can't go, didn't you just say
Well,
they can't?
I'm thinking of retail, like if you go to pick up a drug at the pharmacy, that we also have mail order for that type of medication
And I
as
don't
well.
know if
That's not
our-
required to go through, you're not required to go through Cigna home delivery for a regular medication that you pick up at the pharmacy.
Right, so
But a
just for
specialty
specialty.
drug, you're required to. When you said, maybe I lost you somewhere, but you said that the mail order is better for consultations, and this isn't even what our presentation's about, but that just struck me as, I don't use the school system, but we have the same situation with the insurance company that I'm on, and whenever I'm required to go through mail order, I'm in an array of 1-800 numbers for help, and it's super frustrating. So it concerns me. I just want that out on the record that our employees, and especially that are on specialty drugs, they're probably the most vulnerable employees, are now lost in this array of 1-800 numbers to get help when they could just go down to their local pharmacy or CVS like I prefer to do and talk to my pharmacist.
So I would also say that there's a difference probably between your general mail order and what the specialty pharmacy is doing. And so Accredo literally has 15 pharmacies within a pharmacy, if you will, of pharmacists and nurses who are specially trained in MS. They are not on a time clock with their phone call. They are able to educate you. The nurses do an intake of that member who has a new diagnosis to ensure that they know exactly what to expect with their medication, with their disease state. They get them social care, so if there's financial need. As a retail pharmacist, and I'm just know what I've seen is having done that, there's no way I can provide that kind of time or attention to a specialty drug like that where the member really needs it. An MS patient who has not in the middle of an exacerbation, for instance, is about to take a medication that may make them feel like they have the flu for the next 3 days, or they may have an injection site reaction. If they're not told about that ahead of time, they may stop taking the medication. So there's definitely a difference in the ability of the clinical time and management of the members from a specialty perspective. I actually spent a lot of time at Accredo. I worked there for 4 years as a supervisor over the pharmacist, having seen the interactions with the patients. So it is quite a bit different than a retail setting. Again, I'm not saying that pharmacists in retail settings can't provide that. There's constraints around time especially.
Is the AWP divided between generic and specialty or overall?
There's different
You said AWP
discounts.
minus a certain percent. Is that based on specialty or generic, or is it overall?
So I'm trying to go contract off the top of my head, so I apologize, but your specialty generics are actually in with the generic mail discount. Your specialty brands have their own through the mail, I believe. I apologize, I'm trying to do
No,
that
no, no, I
off
would
the top of my
never
head
ask
from a
you to do it.
contract
I just-
perspective, but
From a philosophical perspective,
yeah, there's
we have-
there's a generic discount guarantee, there's a brand discount guarantee, and then specialty, there's some nuances sometimes in terms of how the specialty is bucketed with mail order. Your generics are actually, if it's especially generic, it's actually bucketed with your overall specialty, which is actually better to have, like, if that makes sense.
Sure.
So Jeff, we do have it contractually listed for every drug. There's average wholesale price, AWP, that's decided by a non-affiliated vendor. There's 2 in the country that decides the average wholesale price. And then for every drug within the contract, there's a percentage off. Some of those range from 14, some are over 20. It just depends on what the drug is. So, but in aggregate at the end of the year, Cigna's contract with us guarantees we will make that in the aggregate. We had a true up at the beginning of this year, and I think that you said 140. I thought it was 193,000 was the true up. Quarterly, we get rebates on all of our brand drugs, our specialty drugs, and I think we got about 2.7 million, Bonnie, is that correct? In specialty, but we have a slide that's going to be in the back that kind of shows you what our actual spend is, and I think when we get there, you'll be kind of surprised at what that is. As a percentage of our total medical spend, pharmacy is actually down over the past decade.
So there is a place in our contract I can go to look at AWP and the percentages that we're supposed to be, then the overall aggregate. So.
Right.
Yes, that is considered proprietary, but you can come into my office and I can show it to you.
But those are an aggregate, and so what you can't do is take a drug and say this drug is not achieving that discount. It is an aggregate guarantee, so that is where it needs to.
At the end of the year.
It's not a per. It's
but
not.
We do have a per drug contract.
Per drug type. It's per drug type. So generics have a particular AWP brand. So it's not a per drug contract. It's an in aggregate for drug type.
So
all the brands.
So what I'm
that
hearing
we
you say
use-
is there's not one AWP minus a certain percentage for each drug.
Not per
rather
drug.
All generic
Per drug type.
specialty.
Right. So all the brands we
I
have to
can
achieve
certainly show it to
AWP
you.
minus.
I have no problem showing that to you.
And
if
I
you have
would
questions,
welcome
I can
Aon
certainly
to
show.
step in because I'm the clinical account manager, so I'm trying to.
You have discounts at every channel, specialty, retail, mail, 30-day, 90-day, brand, generic. They're all aggregated. It is not a list of amoxicillin and omeprazole. It is just a complete by-channel list of discounts. That's what she's stating. That's what we measure. That's what your true-up and guarantees are based on every year. That's in the contract. So that's all reviewable. We or another firm can audit that. They do a true-up, we double-check with an audit. It's all verified.
And that's standard industry,
pretty
how
common.
we are pricing.
So in the essence of time, are we okay to move on?
May I ask another quick question? You mentioned earlier, if a doctor says this is medically necessary to have a brand name and there's a generic available, we are forcing them to pay a higher cost for that, is that correct?
We are. There's a slight difference when there's particular drugs, which they call narrow therapeutic index drugs, which is a brand, even between brand and generic, doctors, it could be an issue to change them. Thinking of antiarrhythmic type drug or blood thinner, even Synthroid is one of those thyroid medications. So there is a list of drugs where that penalty does not apply. But if your prescriber says that, no, absolutely 100% it has to be brand Lipitor, then you can get that, but it will be the differential because there's so many different generic opportunities.
But it's on the employee to pay it, okay.
That's been in place.
Yeah, and I've heard, and personally, and just know representing the BFT, I have heard that complaint from members not understanding why if their doctor says they need something, that they're being treated differently by the plan. But I know that's just for everybody's awareness.
A lot of times there's coupons involved in those decisions as well, which has members utilizing a brand name drug for much unnecessarily. It doesn't hurt the doctor to write dispense as written, it's mandatory. So it really has a loophole closer with that caveat where we basically clinically believe that there truly is a difference between brand and generic that we don't differentiate.
And real quickly, are we okay to move on? Okay. And real quickly, as Kelly said, you're running really well compared to Cigna's book, but compared to school boards, you're at 63 versus $97.
Thank you.
I mean, this is an excellent result for your pharmacy.
I'm going to skip this for the interest of time, but this is some savings through our utilization management by $710,000 per month.
And preventive care, you're spending 2.4% on preventive care. You can see your cancer screening rates for yours results for compared to the norm at 72%. You're beating the measure. You're a little bit low, it looks like, on colon cancer screening, so I think room for improvement there, 45%. Preventive care by employees, spouse, and dependent. The employees are getting most of the preventive care utilization compared to spouses and dependents. Same for, I guess, the dependents are getting the most visit completions. Telehealth connection, really good results here. If you go from 2 to 72 last year with 1 telehealth visit on the bottom left-hand side, up to 379 that had at least 1. And then 46 last year with 2, and 73 this year, and then 20 with 3 visits, and 51 with 3 visits this year. So that's really resonating well with your employees, and we'll continue to promote that as we move forward. This is your outpatient utilization management for high-tech imaging, medical injectables, so on and so forth. You see, last year we avoided 874 of these areas, and then 772 were avoided this year, saving Brevard Schools about $2.4 million versus $1.8 million last year. So really good savings for you for outpatient utilization management. And within that category, 693,000 was the highest, and within that, it's sleep therapy, that you can now do your sleep therapy at home, as opposed to an outpatient hospital setting to get those results. Okay? And these are the numbers of people that we outreach to. And I want to real quickly mention to you, we talked about the high cost of drugs. Gene therapy is an area now where they're able to cure some diseases, but there's 2 medications in particular. One's over $850,000 per injection, the other's $2.1 million. And so rolling out on April 1 is a program, our Embark program, where the charge is 99 cents per member per month, but any cost of those drugs does not hit your claims experience or hit your stop loss. So it's a way to help protect your plan. And there's going to be, 10 to 20 maybe more drugs coming out in the next 5 years in gene therapy. They're the most expensive medications possible. So I want to make sure that we mention that to you as well. And then the collaborative accountable care, or this is reimbursement arrangements that we're moving to in the marketplace. I think we already had one in place, Ron, with Parrish, is that right? Parrish. And then we're working with Health First and Stewart as well, to get these collaborative accountable care arrangements in place, which really reimburses the physicians and hospital systems based on the value and the clinical care outcomes that they achieve, as opposed to just paying them every time somebody goes to the doctor.
Thank you, Brian and Kelly. We appreciate the presentation. Dave, if you could come up to talk about Marathon Health, and please be cognizant of that time.
Good afternoon. It's a privilege to be here. I think it was this very room over 3 years ago that I was with this group talking about your vision, our vision for on-site health. So my job today is to provide an executive summary of a much more detailed review that was presented 3 weeks ago here to the administrative staff of the school district. Again, my name is David Demers. I live in Naples, drove up this morning. Used to be based in Burlington, Vermont, where our headquarters is, but I saw the light and decided to move down here. By training, I am a master of public health. So if clinicians are trained to study disease in individuals, I'm trained to study disease in populations. I've been doing this for 40 years. I'm responsible for all of the analytics and reporting for Marathon Health. Everybody on my team is an MPH. Five people working with me. So my job is to provide you an executive summary. I have 9 slides. I'm going to stay very high level. I'm going to tell you what I think is working well. I'm going to tell you where I think we need to do some improving. And I'm going to tell you what I think the key takeaways are. I'm joined by Gabe Kramer here, the gentleman in the yellow shirt and red tie, who is the account manager for the school district, who works very closely with Mark on a day-in, day-out basis. Okay, we have 3 health centers, as you know. The central location here in Viera, the north location in Titusville. There we go. In the central middle school in West Melbourne. Those were all live basically 2 years ago, August 17th. This is a snapshot of the volume at the health center on a monthly basis. The green is sick care, acute care, and the blue is preventive care, risk mitigation, condition management. The volume from year 1 to year 2 has gone up 10% year over year in terms of the visit volume to the health centers. Now what's significant is not only has the volume gone up, but the number of unique employees using the health center has gone up let's see, I believe that's 16% from year 1 to year 2, 15%, and then so far in year 3, up another 16%. So we went from an average of 356 employees, unique employees every month using the health center to 409 to 474. So this is a positive in terms of more people using the on-site health center. One of the very positive things going on here is the screening rate. By screening, I'm talking about biometric screening, blood pressure, height, weight, BMI, blood sugar, and a lipid panel, which is total cholesterol, LDL cholesterol, HDL cholesterol, your triglycerides. That's important because half of conditions such as hypertension and high cholesterol are undiagnosed. People don't know they have it. And so it's important to find those conditions. They're asymptomatic, but if they're not addressed, they cause bad things and cause expensive claims. So your screening rate here is very, very good. The number of people identified at risk is pretty high, 60%. Mark, yes?
Dave, real quick, just a question on capacity. If we're at 474, what would our capacity be to continue to expand with our current clinic number?
You know, I'd have to do the math on that. Off the top of my head, Mark, I don't know what that number would be, but I can get that for you. So we have good screening rates, we have a significant risk pool. Here's where I think our opportunity lies. Rule of thumb, the gold standard is to get 70% of patients identified as being at risk engaged with one of the clinicians in these health centers. Engaged to begin a journey of reducing the risk that's there. That could mean getting on medicine, it could mean learning how to shop better, prepare foods better, to manage stress, to lose weight, to quit smoking, any of a number of things that the clinician and the patient together plan. That's the whole purpose of what we're trying to do here. What we have right now is 40% of patients who are in this high-risk group engaged in working with the on-site health center clinicians. We have a little less than 20 school districts nationwide. So if you want to think of that as kind of the peer group, or we call it a vertical, the average school district benchmark is 58%. We're at 40%. So our challenge is to get more of these people engaged with the on-site clinicians. And we have a plan to do that. We've added some additional staff. But this is a huge opportunity, and it's a huge opportunity because what we know is once we get these individuals engaged, their outcomes are very good. And as a matter of fact, Brevard is beating the school district averages in terms of clinical efficacy. With mitigating blood pressure, you're right at where the average is. 50% of people with high blood pressure are reducing it. And they're reducing it by a lot. We do have the detailed data in terms of the size of improvement that's being made. That's actually reported to you every month. The impaired fasting glucose, you're beating the average. Total cholesterol, the whole lipid panel, you're beating the average. And even BMI, you're beating the average. This is year 1, this is year 2 in terms of the percent of patients that are making clinically measurable gains, improvements in their health status, reducing their risk. This is a big deal because if you're getting someone with diabetes to the standard of care, it means fewer admissions to the hospital for ketoacidosis. If you're taking care of someone who has acute asthma, it means you keep them out of the emergency department. All of these things mean fewer specialty visits, fewer visits to the hospital, admissions, use of ancillary resources, and so forth. It's a big deal. And so we have great results when we get people in the saddle, but we're not where we're at where we want to be in terms of getting as much of that risk population into the saddle, and that's our challenge going forward. What we do know, yes?
And this may go back to the question about capacity. If we were to get to the 58%,
yep.
Do we have the current capacity to get to 58%?
I believe you do. So we've got to get people not just going for acute care, not just going to get their screening, but we've got to get them engaged as a member of the clinician. They're there, and we can do it. It's just going to take some effort on our part. We do have a series of things planned. It's outside the scope of our meeting here today because of the brevity of the meeting to go into that in detail, but that information can be provided to you as a follow-on.
I'd like to ask a question.
Yes, ma'am.
So I'm looking at the different sites. So if we want to get more people involved, Vieira, Titusville, and West Melbourne, there's the whole Cocoa and the central area, Merritt Island, Cocoa. Any way that you can put another?
Our biggest complaint from employees is not been so much mainland Cocoa, it's been beachside people. Beachside people.
That makes sense,
Because a lot of
really.
people, Port St. John Cocoa, Titusville is very accessible, Vieira is very accessible, you're kind of 6 of one, half dozen of the other. It's beachside people that we've lost.
It's a great question. We have done what's called some geo-axis analysis using your zip code data, and we have thought about a location that would help, a fourth location that would help.
Good.
And we're going to be talking about that going forward.
Thank you.
So we know we can get good results if we get them engaged, and it translates to a lower per capita spend. People we're working with, because this risk is getting mitigated, because they're at the standard of care for their chronic conditions, are using these downstream resources less, and the per capita spend of the cohort we're working with compared to those that we are not is about $250 a month less. So good results, lower spend, we got to get more people in the pool.
Excuse me, how does, like going even back to Cigna's numbers, they have total engagement is actually down, you know, from their numbers, and also the health assessment completions were also down. How are you all coordinating that? Are they the same people that you're not getting, that they're not getting also, that are kind of not in your population?
I'm not entirely sure. We could probably try and figure out what definitions are being used for engagement. When we talk about engagement, we're talking about someone has had a face-to-face visit with a member of one of the health center teams.
Like a coaching type engagement.
Yeah.
Ms. Butterfield, could you clarify what pages you're comparing?
That was on 11, on the bottom right-hand side.
Well, visit completions, you're looking at that?
The health assessment completions is the trend is down, and then the total health engagement is also down. And Tina brought up a point of the medical spend is still up. So part of the, attractiveness of the investment of the clinics was, to kind of disrupt, care to go to the clinic. So we're still, in other words, paying for outside visits.
Yes.
On top of, the investment in the clinics.
Right. We can't redirect all of it. And I think for overall utilization, I think we're pretty close to what the original projection was. I think the original projection was 30% year 1, 35% year 2, 40% year 3. For an on-site health center where the health center's in the building where everybody works, it typically goes 50% year 1, 55% year 2, 60% year 3. So use rate is important, but what I'm focusing on today, and the message I want you to hear, is it's the high-risk population engagement rate, which is really the number you want to focus on. It's great that someone who's basically healthy uses the health center for an earache or a sore throat. What we really want to do is find people with diabetes, hypertension, and help them get their condition under control or to mitigate the risks that they have. Very quickly on the pharmacy side, the health centers.
I'm going to have to stop you again, I'm sorry.
Yep.
You just said our contract was 30, 35, and 40 over 3 years. What is our current utilization rate?
35%.
So year 3, we're 5% below the projected utilization?
Well, we just started year 3. So 30, 35, 40.
Okay. Yeah. So we closed out year 2 at 35%?
Yes, sir.
Okay, thank you.
Pharmacy. These are therapeutic classes of medicine. So this is the medicine that's dispensed in these health centers. 9,360 months, if you will, of medicine was provided.
average fill costs of $8.41. So Brevard spent $78,700. That's our cost. We get this medicine through AS Medication Solution, which is part of SaveRx. It's extremely inexpensive. We pass it through to you at our cost. We provide you with the invoice that shows all the medicines that we bought. We're not marking it up a dime. There may be a better benchmark, and our colleagues at Aon may be able to help us with this, but what we've used is the ESI national average as a proxy for planned spend. And if you use that $78,000 in medicine probably would have cost the school district closer to $500,000. So a proxy for the net savings of these dispensed medicines is around $450,000.
Excuse me, clarification. I thought when you guys did your presentation at the beginning for the clinics, your particular presentation was the list of medications, you basically absorbed that. So
I think that's right.
You're not passing on the cost. So when we talked about maybe expanding the list.
I stand corrected. It is absorbed as part of the base budget. What I'm saying is that if those dollars had not been
if they hadn't been going to the clinics to get the prescriptions, they would have gone to a pharmacy to get them, which would have cost us.
But we're also paying for the clinic, so we're not realizing all of that savings.
Are these the only medications that they can get at the clinics right now?
I think we're stocking.
There's
60.
Yeah, there's quite a few. There's
60
about
meds.
15 to 20 that are refillable on a consistent basis, and another probably about 40 or 50 that are.
These are the most frequently used medicines. So for people with high blood pressure, you're going to have hydrochlorothiazide, the diuretic, enalapril, amlodipine. For diabetes, you're going to have insulin, metformin, and so forth, and then all of your antibiotics and so forth.
And that list of medications should have been included in the recent newsletter that went out to all the members.
Why did you just include these in the presentation to us? Are the others just so rare they're not used, or are these the highest cost savings?
I'm sorry?
What, if we're giving out 60 medications, why did you just pick these few?
These are categories.
These are categories.
Got it.
Yep.
I got it, okay. Thank you.
So can I ask a quick question? So all of these don't pass through our current pharmacy program that Cigna is running. This is an entirely different subset. And you give these costs and this to our plan so we can review each one of these, correct?
Yes. All of these drugs are included in our annual fee paid to Mara.
Right. There's a cost associated that they're giving to us for each one of those bills.
No.
There's no cost. It's all included.
I mean, it's not costing us, but there's a price
not a
for each
line
one of
item.
those. There's a line item. Or is it just saying that we're dispensing high cholesterol, 1,194?
How does that, Bonnie, what does that look on the bill? Do you see any
We
breakout?
just pay a flat fee to Marathon, and it includes the drugs and the management.
Yeah.
Marathon.
So
It's a flat.
we will need to get a copy of that so that we can verify.
So there's no way to cross it compared to the cost of the pharmacies that we're actually paying now. There's no way to say how much that costs in your clinic to us as opposed to how much that costs towards I know we're paying a flat fee, but if we're going to steer more of our people towards Marathon to get drug dispensing, then what is the savings going to be is where I was at. Does that make
So
sense?
the best way to do it would be if we could get our hands on it. It's not always easy, but to get the actual PBM paid amounts. Your pharmacy benefit manager, actual, contracted paid amounts for these meds. They don't like giving that information up. But if we had that information, we could then compare it to what the actual cost of this stuff is. That's why you heard me mention what we're using as a proxy in lieu of that is Express Scripts International national average for what the PBM rate would be.
So we have their information. Will you provide yours so that we can compare it?
Sure.
Yeah.
And then you're using Express Scripts national average. Can you provide that for us for each one of the drugs for the past 3 years?
Yeah. Well, I don't know about if we can get it. We get it by therapeutic class. I don't know if we can get it by individual drug. I'll look.
Well, and just the other thing to point out that the majority of the medications that are going through the health center aren't meant to be refilled on a monthly basis. It's usually the initial startup
Sure.
outside of those 20, so it wouldn't always be running through the health center.
All right, I'm very sensitive to the time. So 2 more slides. So these are the fees being paid to us to care for patients at those 3 locations. It's really, I guess this is an error on my part. These really aren't a separate line item. They're in that base fee. So that's an error on my part, overstating the total fees. The clinic savings, the pharmacy savings, I think, are what we reviewed, and then the savings from risk mitigation and the lower per capita cost for people we're caring for started off slow, but it's just north of $5 million in year 2. That number can be bigger if we can get more of that risk population not identified, but engaged. So it was basically a break-even year in year 1 and about a 1.8 savings in year 2. I think the bottom line is that while you're running a deficit the past 12 months, that the deficit, could be somehow Aon's logo cut on this slide.
It's on all of them.
It could have been $2.5 million larger had those 1,600 individuals that we've been caring for not been receiving the care that they're getting, the excellent care that they're getting, in the way they're getting it at these health centers. Basically the cost could have been that much higher.
Can you help me understand the last chart, the clinic savings? I don't understand how you come up with that number. It might just be that I'm not aware.
So if there's 2 ways to do it. One is comparing actual to trend, which Aon already went over with you. The other way to do it is taking the difference in per capita spend between engaged and non-engaged cohorts times the number of people who are in that engaged cohort, which is roughly 1,600 people. So 1,600 people times $3,073, I think, is just north of $5 million.
So from the time each WellCare center is built, when do we start seeing a return on investment? And what is the return on investment on each WellCare center?
So this is your return on investment, and it's probably...
Okay, so if we build a new WellCare center, when will we see a return on investment, and how much?
In general, what we see, not always, but in general what we see, so the database that we have now, we're in 44 states, we have 110 employers that we're working with, 400,000 covered lives, and 160 health centers. Year 1, the goal is to break even, cover your costs. Year 2 is to get to 1.5. Year 3 is to get to 2, and if you can, get to 3 to 1. But 2 to 1 on medical savings is typically what we see. So if you open another one, and we'd want to make sure the numbers, we did all our planning in terms of demand and staffing, and that it would fill, and that it made business sense, and we would do that. Year 1, break even. Year 2, 1.5. Year 3, 2 to 2.5.
So my concern, and Amy brought it up, or Jeff, one of them did, is the location of the WellCare centers and not having one on Beachside, and then also I think in southern Palm Bay as well. And I think we really need to consider, is this going to be our plan going forward? Because I feel like we're not quite all in with this. Is it really saving money? Is it not? And if we're having trouble getting these high risk and chronic usage care at the WellCare centers, which it seems to be the major purpose of them, should we continue down this road? They're just driving here. There's been urgent care on every single corner at this point. Are we better off going back to, urgent cares and preferred health centers, or is this the approach we want to go with? And if it is, we need to be all in and make it accessible to all our employees, because as of now, it is not accessible to all our employees.
Can I make a comment on that?
Yes.
I just have to, sorry, I can't help myself. But urgent care is not gonna give you what you need, because urgent care is about efficiency, getting someone treated for the symptom, and getting them out the door, and then getting the bill. What needs to happen is people who have these underlying risk factors need to work with clinicians who have the ability to take the time and have the skill to work with them, to engage them, to get at those underlying risks. A very different model for how care is delivered, but it ends up producing some very powerful results. I think you already are getting savings. It's just the opportunity to do even more is there, both with the 3 centers that we have now, and then, a good discussion about whether we should open a 4th. But it's not, urgent care is not going to get you what you want. You're just on a treadmill. All you're doing is treating the symptoms. You're not doing anything to remediate the underlying risk, and that's the key.
What do you?
So, sorry to go on your point though, Anthony, of what we could do if possibly this isn't working out to the extent that we wanted it to. Some plans are doing direct primary care arrangements with physicians where people get to pick their doctor and they're paying for that every month. So you get your coach that way. So we haven't really ever talked about that on Siac, but that's kind of a new, interesting trend.
Are you talking concierge?
Well, the new term is direct primary care. So, and employers
As long
are
as my
paying
brains.
for that. So that is just something to kind of throw out there today. Keep going.
So I'd like to, just to continue Mr. Colucci's point, I think it would be, and I can work with Mark to finalize a request, I'd like to look at a more in-depth analysis of the utilization of our current wellness clinics to understand what is the deferred cost savings to the employee, what is the deferred cost savings to the employer, as well as what our capacity is currently, because we've got to understand what is our current capacity before we expand capacity, and then what is the projected cost savings again, particularly if what I hear you saying is enhancing preventative care coaching service through our wellness clinic. So I'd like that to be and maybe, I don't know if that's done in conjunction with Aon or how that worked, but I'd like a lot more information and data on the utilization of our clinics as we look forward. Because I don't disagree with Mr. Colucci. We've got to, making the decision to expand is much greater than a vote around the table. We've got to know definitively, not an I think kind of statement of exactly what our savings is for this plan, or we look at other options.
And if I may, I think there has been a point, and I think the chair and myself come from different parts of the county. There's been folks have mentioned Beachside, but I've also mentioned that Palm Bay is 20% of the county. It's very large. There's not one representing that south part of the county. What do you think the feasibility is of having not just one, but 2 locations? Because I respect why people in Beachside would also need it. So anyhow, that's just further consideration.
When we started down the path of going to the Marathon Health Clinics, which was a great idea, our current urgent care infrastructure was not nearly what it is today. There is infinitely more urgent cares out there. I think the other number to keep an eye on is, although we've had these clinics, how much are our urgent care centers still being utilized? Because the last time we looked at it, the numbers were flat, consistent, going back years to go. So that was, I think, 1.5 years ago. They were still getting the same number of visits at our urgent cares, even though we've introduced the Marathon Health Clinic. I think the big sell for Marathon Health Clinic is that they are going to take over and take care of those higher costs and do a better job at wellness and everything else. But the problem is if we can't get the percentage of people buying into it, then there's the opportunity to move forward. I had a question, is that when I did the numbers, it looked like we had about 5 visits per day on average or something like that across. What is the capacity moving up? Meaning we're underutilized in those locations. Is it like a per visit that you can look at? Or is it more, this takes longer than others and there's no way
I
to?
think the current run rate on visits per provider per day is closer to 10.
I want to say Gabe gave us that information a few visits ago. It was a graph that said like Dr. Gregar can see an average of 12 patients a day, and at the central clinic it's
That's right.
I think you gave us that.
So you have an average there, and then you have the total that we have.
Right.
Right, okay, so we got those numbers, and then do we have a list of all of the procedures and the numbers behind them?
Yes.
For each one of the procedures that are going
We get that
forward?
every month. We give that to you
Okay.
every month. There's a detailed report that we can provide to you. It's called the CAT report, Clinical Activities and
Yes, sir.
Trends. And by the way, let me, if I may, answer
Yes, sir.
one more comment on, I love where your brain is going on the capacity. So to answer the question, 12 patients per provider per day is our target, optimum. Like that's with the, all cylinders firing and cruising down the road at third gear. The model begins to break down at 15 patients a day. It's very hard to engage the patient, to work with them to mitigate risk, to do all the things you need to do north of that, because then you kind of turn into what your average primary care practice out in the community is doing, which is 20 to 25 patients a day, and they do not have time or the capacity to do the stuff that we're talking about. So 12's ideal, 15's the max, it breaks down after that, and we're currently at right around 10, so we do have room to grow.
One of the other issues that I was looking at for cost savings in our current clinics is that there's a lot of other options that we could look at. Low number MRIs. There's things that you can do. You can expand services within the clinics to capture a lot of what we were talking about before when you say a lot of our outpatient stuff and our MRIs and everything are getting sent to these other areas. There are some clinics in other places that provide those options, and we would be able to drive down costs. So is there any, beyond capacity of building more in other places, have we discussed possibly about opening up more options like the RX, like those to reduce costs?
We can have that discussion. It's another good thought. You're not going to do MRI in these
Not
health
MRI,
centers,
but
X-ray.
X-ray, that's what it was. I'm sorry.
More lab work.
More lab. You can PT. You can do behavioral health. Behavioral health is right now a huge need. And 2 years ago, we had 0 licensed mental health counselors in our health center. We now have 32. And a lot of employers, that's just a huge issue. There's some school systems here that have gone down that
Do we
path.
just to give you a little bit of history, the reason why we didn't bring in X-ray into the clinic was communications with other districts that did include it. And they have them, but they're not utilizing enough of them to really warrant the cost.
Yeah.
So that's why we send them out to the X-rays that are close by. And all of them are on the approved RX list, so we're getting the best pricing possible.
Okay.
So that's why we chose to do that. We can certainly expand the operations of the clinic to that, but really what today was just supposed to be a high level review. I send out copies of all of their slides, so if you want to go back through and look at what I've sent out to all of your Siac members, Marathon's health, including their averages, were presented in, was that December, Gabe?
About 3 weeks ago.
3 weeks ago. No, they weren't part of that. This was the last.
December, right.
In
And
December.
we're meeting again on Thursday.
So the December site will have the averages that we've talked about. This was just supposed to be a high level overview.
So I wanted to caution that when we're looking at the utilization, we're not looking at the average of all three, because from what I've seen, the problem is in the south area well care center that is being underutilized when Titusville and here in the parking lot are going well. So we may, if we have one problematic well care center, we may never reach the utilization. So my solution is just to forklift that one in the south to a different location, if we can do that.
You mean further away from Palm
Matt,
Bay,
you'll
so
do that,
further-
right?
No, further into Palm Bay.
Into Palm Bay.
Well, and I would just add, so the provider at the south location is on her own, whereas the other two have 2 providers. We do look at her numbers, each of the providers separately, not by center, but by provider. And she's at 11.8 visits per day in the month of January.
Yeah, and I'll add to that, I think there's some stability that we needed there, and as folks that know her now, my wife's used her multiple times since she's been there, that changed things. I think that's encouraged more people to use it, so I think that's a good thing.
And something else to remember, what we did at the north and the central is we added a second provider. So before that, those numbers were closer to 14 a day, which is what they were saying, because we added a second provider, that's lowered the average of each one of those clinics. They're continuing to build their practice. So they will reach a point where they're at their max as well, and that's when we are looking at possibly adding another clinic or possibly two, depending on where that goes. But that's kind of affected the average, getting us down to about 10.
Can we drill down, Mr. Langdorf, on when our employees are visiting the other urgent care centers to maybe show the discrepancies in times? When they report, they actually send in a time?
I don't know if we have the time on that, but we certainly have the visits per day.
We have visits by hour of day.
But you don't have it for the
urgent care centers. That's why I'm saying before we dive into putting one beachside, it would be nice to look at each one of the urgent cares that are beachside to show how they're being steered there. Then cross that into what times and everything else, and also Palm Bay and other places. You can do an analysis.
Late nights and weekends.
You can do an analysis of it. The other piece is that I wanted to ask, what percentage, minus the driven for the BMIs and all that stuff, which is required by the health plan, can we identify how many employees past that are actually visiting our well care centers? Like what percentage of our employees that are on the health plan?
Yes.
Okay, all right.
We can provide those.
Perfect.
That's not a problem. Dave, would you go back to the last slide?
Thank you.
The one thing that I did want to point out to you is when it comes to ROI, I think this is important here. This is what it costs us annually to run our clinics. This is the clinic savings. So what they did is they looked at Cigna's records, right, Dave?
Well, we have the same data.
Right. So they looked at Cigna's records at those folks with chronic conditions. Had those chronic conditions not had the well care center, the cost for them would have been $5.5 million. But because those folks are getting care, that's where our return on investment is. We're saving 2.5, almost 2.6 million on the chronic care treatment. Would you agree with that, Dave?
Chronic and at risk.
Right.
Can you explain that a little more in depth? I think that.
Yeah, and I just want to add, I mean, obviously we're talking about theoretical opportunity costs that we're saving in the future on these, but my concern would be exactly what is that population we're looking at when we look at the higher number that we're comparing to. How is that really a bundle of patients that really matches what we're bringing in?
Yes, we can absolutely define it precisely. Hypertension is 140 over 90 for high risk, 120 over 80 for moderate. Blood sugar is impaired, glucose of 100 milligrams per deciliter. I can go on, but there's specific thresholds clinically that have been established for each biomarker. And the group that's been identified as high risk would be people who are exceed that, or who have been identified as having a chronic condition. Not everyone with high blood pressure has been officially identified in the claims data as having hypertension. Once we verify it, and they would move into that category. But that's why I'm saying it's a little bit broader than just chronic. It includes people who are at risk of developing chronic disease. And that the combination of those two groups are what we call the target population. And that's the group that we're in the opportunity lies.
I tell you what I will do is I will get with Dave and Gabe and Brian afterwards. We'll work on that and I will send out that data so you will all have that. And I'll do my best to explain it, or I'll get them to explain it, and I'll pass that along.
For clarification, are you saying that number does not include savings from acute care?
There is acute care built into that, yes.
As saving?
Yes.
Okay.
Is there a way to track, when I look at this chart keeps bothering me and I couldn't figure out why. Is there a way to track, because you have either have gone to our health clinics twice or haven't, and the numbers are skyrocketing if they haven't. But is there a way to track people that have gone to their own primary care? And so I'm sure there's this group of people that get no health care, no preventative care, no well care, and their numbers are high. But isn't there a group in between here that has their own doctor somewhere?
That would
They
be the
are
group
doing-
on the left. Anybody who has not used the health center is in what we call the non-engaged cohort.
Couldn't they have their own doctor?
They most likely do, many do, not all, but those are people that are, they're seeing specialists, they're seeing primary care physicians, they're maybe seeing, having imaging done, they may have gone to the hospital.
But they've never stepped foot in our clinic and you're still including them in that?
No, coaching visits. Coaching
So they've been to our clinic?
They could have
The
been.
bar on the left is just the people that we've engaged, and the definition of engagement is at least one face-to-face visit with a clinician, okay? The group on the right has never stepped foot in the health center.
But I think what you're saying is that people on the right, some of them might be actually taking care of themselves, but they're mixed with people who are not going anywhere, not really
Yes.
doing anything. So you're not having really apples to apples comparison.
Right, we're
Yeah.
not getting total accurate information. I feel like there needs to be 3 columns. People that start taking care of themselves, just not with our.
Well, if someone is taking care of themselves and has not incurred a claim, then there's not going to be any data on them. We're simply using the data available to us between those two cohorts.
Cigna would have that data, right? They would know that we have people that have gotten their well visit.
Hang on, I should pull it together for you.
Yeah.
Thank you, Dave.
Thank you. I appreciate your attention. I went a little bit over, but good dialogue, and we really are so pleased to be part of your community.
Thank you.
All right, we're going to turn the time over to Aon now, who will provide us with some benchmarking.
So good afternoon again. I am Paul from Aon, the Aon team here. And we prepared just 4 slides for you to focus on benchmarking the Brevard Schools plan against custom peer groups of Florida public sector clients, either governmental entities, but primarily other Florida school districts. And we did 2 cuts of the data around benchmarking. The first slide is financial performance of the plan. So this is just looking at raw data, key metrics of the financial performance of the plan. And the next slide we'll take you through will be more around plan design and contribution setting. So we looked at 7 key attributes of the financial performance of the plan relative to this custom peer group, which again is 9 other Florida school districts and 1 other county government. And the results of that peer group is in this very first left-hand column. And then the Brevard results are on the 3 columns to the right. And just to keep this easy of reading, we're doing some color coding on the right-hand side, which is just high level. How do the Brevard stats look? Are they at market yellow, ahead of market more favorable green, or a little behind market in the red? I'm happy to report that of these 6 cuts that we looked at, 6 of the 7, they are at or ahead of market, the peer group from a financial performance perspective. And 1 is about, at market, maybe a little behind. And just ticking through these pretty quickly, but feel free to ask me any questions as I go through. First, we looked at how big is the family size here of employees who enroll in the Brevard plan versus the peer group. And on average, for every employee, there's almost 1.8 people covered in the household. And that's a little ahead of the peers at 1.6. So 2/10 more covered people in the Brevard plans versus the market. So in other words, just to orient to the chart, 65% have smaller family sizes than the Brevard plan. So Brevard's got a little bit bigger family coverage than the peers. As you tick through some of these other ones, when we look at the claims per member per month, this is medical, this is pharmacy claims. We've also added in clinic costs. So you all have 3 clinics. Some of our other clients have 2 clinics as well. We've added that into create these per capitas. Your per member per month cost for 2019 at about $484. So that's the claims that are hitting the bank account before employees pay payroll contributions, but after they have paid through their deductible and their out-of-pocket. And you can see that compares favorably to the peer group at $522 per member per month. Said differently, 65% of the peer group has higher per capitas than Brevard. So that's a very good, strong result. Claim cost trend, you all from the period that we looked at, very similar to the Cigna numbers, running at about 3.8%. So that means, what you're spending today, the latest 12 months in 19, is 3.8% on a per member basis from what you spend in 2018. 3.8% trend, very similar, I think, to the Cigna trend, which was a little over 4%, but we're looking at different time periods. And you can see that the average is 3.9 for the peer group, but there's a wide disparity in those results among the peer group. So when we look purely at the median, you're actually beating 65% of the peers, because there's some negatives and there's some big numbers as well to make that average. Another key metric is employee cost share. I know we talked about that a little earlier. Again, employees contribute in the plan through a contribution, through payroll, and through an out-of-pocket when they use the plan, a deductible, a copay, or co-insurance. This is measuring what's the average of the charges that hit the plan, what's the average that employees are paying or members are paying when they use care. And for Brevard, it's about 14%. So of every dollar that hits of a charge, they're paying on average 14 cents, and then the plan is paying the other 84 cents. And that 14 compares to 12 on average, and that's, a little better than the median. 65% are, a little less favorable than you all. Payroll contributions, really right on market here. Your average contribution, $123 per member per month. Benchmark 117, so you're a little more aggressive on that, but not by a lot. You're right at the median. And then I know Cigna covered two key stats. Pharmacy generic dispensing rate, very favorable, 91%. That's beating 75% of the peer group, so that's a very strong result. Yes?
Going back to the, I think for, the SIAC members and then obviously the board and Mr. Mullins was a doctor, sorry. Doctor, okay. Anyway, those numbers are kind of important, because if everybody's worried about, what salaries are going to be and how that's going to go, if the school district decides to increase more, and we're already above that,
you're talking the out-of-pocket, the 14%.
Then you get what I'm saying? Then the increase in salaries is going to be absorbed more with healthcare cost if we go up on the cost share with the employees. So this is telling me we're already higher than the normal.
Against this peer group, you are 2 points more out of pocket cost share than the peer group at 12%.
Why is that a green?
Out of state, correct?
Yeah.
Because it's the health plan. I asked the same thing, it's the health plan
Right.
perspective,
This is purely
not
how the health
the
plan perform, the
employees.
financials of the health plan.
Why were these districts selected as the peer group?
Sure. So we selected these because they were Aon clients and we had ready access to this data. It wasn't all publicly available. This one, we did expand to local districts because that is publicly available. So we were able to get their trend information, but these other elements, we only were able to get it from Aon clients that we had ready access to that data. Otherwise, we'd have to go to them and ask them for that data to create these results.
Also, a question on the second line, the per member per month there. If you go back to the presentation earlier on page 13, where it talks about the cost per employee, per spouse, per dependent. Obviously, spouse is more, but dependents are less. And if you look at the graph on the left-hand side of that page, you see that we have more dependents than spouses. In other words, based on our makeup, we should be less. So have we, I guess, distributed based on the type of memberships we have, as far as employee, spouse, and dependent?
So I don't want to speak to the Cigna slide, but I think page 13 of the Cigna slide would get at how your per member cost by an employee, a spouse, and a child would compare to their book of business. Mm-hmm. Ours is purely the composite across however many spouses and children they have enrolled versus you all. So based on your mix of enrollment, on a per member basis, you're running that much less than the average.
Yeah, but how much? So in other words, forgive me. Economics is my background. Thinking about some local quotients, things of that nature, when you're trying to figure out what your impact is. So what I'm getting at is how much of that is based on the mix of what's on our plan as compared to what we're actually realizing. In other words, if we had somebody with the same mix, I think that they would also have a lower number, which makes that not look as good.
That's a fair point. So you are true that you probably have more children in the plan than the average, and this stat shows that. So children cost less, so that is part of what's pulling it down. Yeah. So you're right. If we normalized, then I think I'd probably have to take you back to the Cigna slide because they've normalized. They've said how much do your spouses cost versus their book of business, how much do your children cost versus their book of business. Our number doesn't get at that. We're just looking at just composite per member.
How does the district cost compare to peer groups on the per member per month?
So that would be the difference between, so for the peer group, the claims are 522 and they on average charge their employees 117. So let's call it $500. I'm just gonna do simple math, 522 minus 122, call it, I'm sorry, $400 versus yours, which is 484 minus 123, call it 350.
And that's only addressing claims, not premiums.
That is claims minus contributions, and then in addition, you have fixed costs, your stop loss premium, your ASO fee, but those are probably very similar among these size groups.
If I can run through a couple of them real quick. So the claims cost trend rate is the number 3 referenced below. Then
Yes.
the employee cost share as a percentage of gross claims does not have a number.
What did you say? Say that again.
So I'm looking at the 2019 key metrics, and the data sets that are below reference different data throughout. So
Right,
in
yes.
one, they're referencing a number 1, and one, they're referencing a number 2 to expand and contract. But I didn't know, being the fact that the employee plan cost share as a percentage of gross claims did not have a number next to it, I didn't know which one of those data subsets may have been driving that.
Great question. These are all the same group of 10, except for the cost trend. We were able to expand it to school districts around Brevard. So only this cost trend is a bigger sample. That's the 10 plus we bolted on Duval, Orange, Osceola, and St. John's.
So which number is the employee plan cost share as a percentage of gross claims in those data sets below? Would that be the number 1, 2, 3?
Everything here.
This is what the 10 are charging, the core 10. So all these stats are the same 10 groups.
From the first subset?
From the first bullet.
And then Brevard Schools percentile ranking to peers is the one that changes.
Right, so this is Brevard results, and Brevard cost share is 14%. So of the charges, on average, members here pay 14 cents of every dollar of healthcare spend. The peer group, the plan designs are 12 cents.
Let me just kind of clarify something that's important, because again, this is the claims on average. Not all of these peer groups have a clinic, right? And so the clinic access is tremendously important versus other districts that don't have a clinic. We don't have a value for a clinic. So I think you need to just recognize the fact that the clinic model is a positive impact to employees as well as to the cost of the plan. Number 2, I would say, is that when we look again, we'll do some benchmarking, and I apologize for 72 pages. You know, some of them have other districts we're not going over, but we wanted you to have the information because that's the work that we did. The other thing is that PPO plan at the $500 deductible component is again, the best PPO plan that's offered to any school district. Now, that deductible depends on whether you do your health biometrics. So the whole approach is to get people to the clinic, which we want to make sure and use that to capacity because that's a fixed cost to the district. That saves us money to get them to that particular component. If they do the biometrics, we're catching them in early stages as well on your high cost claims, because your high cost claims are the ones that kill you. And some of the IBM Watson data I'll talk about later, but basically we agree with moving more chronics to that space. So I think those are 2 components. Again, this is data, benchmarking, great questions, but there are some other nuances that are important to represent the district's plan. Does that make sense?
Yep. So can I ask a question again? Employee plan cost share as a percentage of gross claims is 65th. Where is the 65th in relation to the 4 data sets at the bottom?
So what we're saying here is,
where is the variance of the 4 data sets being applied into this chart?
I'm not sure I'm understanding your question. What we're saying, for example, with that row is that 65% of the 10 are having a cost share percent that's less than your 14%, and 35, a third of them, have a cost share that's greater than your 14%.
So if inside this 2019 key metrics does not have a number at all, it's referenced back to the number 1 on the data set with no other school districts involved? It's just that there's multiple school districts with multiple bolt-ons that create different anomalies based on each one of these factors. And for me, it looks like it's steering an argument into a green area where it may not be when it's compared directly to. And it's just, I'm trying to hone down on where those data sets are at, that's all.
So I'm sorry if I'm not explaining this clearly enough. There are 10 data elements in this.
Right, and those
11
are...
counting Brevard, so 10. So we're comparing you to the other 10 in here, and 65, so call 7 of them are less than your 14 and 3 are higher than your 14%.
Perfect, and those 10 that are in there are the same 10 for all of them?
They are the same 10 for all of them, except this one we expanded to include other local school districts, because that was publicly available information we could pull out public.
So you expanded the number 3, then you expanded the
No,
number...
we only expanded number 3. All the other ones are the constant group of 10. So there's 10 other districts. All this is against 10, except this one. We can certainly follow up, and I will after this meeting. If I make this just the same 10, so it's apples to apples the whole way down, how do you compare? I think it's going to be a similar result, but we just chose to expand it because we could pull that data.
Sounds good. Thank you.
Okay. Thank you. And again, looking at this, it's purely from the plan perspective. That's the kind of the reading on this.
If there's 10 of them, it should be done by 10% segments, should they?
There's 11.
Plus 1, okay. But it still is not going to be by 5. All of us have 5s that you don't have to be a math teacher to know that part. So are you doing that based, so are you standardizing the data based on where they rank with other ones?
Where you rank
where you rank, or are you doing it based on the actual dollar figures that came out of these areas, giving it a range, that you're standardizing based on a range?
So we're arraying you. So we have 10 data points for this row. You're at 14. There's 10 other districts with 10 other numbers. You're about the 65th percentile. Frankly, we're rounding to get round numbers here. So you're right around 65th.
Got time. Focus.
We covered pharmacy, just generic dispensary, and last but not least, the specialty cost. I think we covered a lot of that. Your specialty spend is about 36% of your total pharmacy. That is definitely at the lower end of what we're seeing other school districts.
What do you mean excludes 1 of 10?
We didn't have the data on that one. So of the 10, we couldn't pull that from the report. It wasn't in their pharmacy report.
So it's
So that's on 9. That's on 9.
Just 9 of them. You're missing one school.
So this is all on 10. That one didn't have it, so it's 9, as noted in the footnote. And this row we expanded with the local. But we'll get you the stat for the same 10, that third row. And again, this is just trying to give you a high-level reading of some of the key metrics on the plan. Any questions there? All right. Moving then from the financial performance metrics of the plan, let's talk a little bit about contributions and plan design. Jonathan and Nadia are going to join me in a moment and talk about two of these local employers, local public entities in a little bit more detail. But this is just a snapshot. And here's the group we can compare against. And this group is different than the prior page because this is more publicly available information. We can go to websites and we can pull what other Florida school districts have for plan designing contributions. So here was a custom group that we created, more what I'll call the Brevard custom peer group, as opposed to the last slide, which was a mix of that and who we had data for. So just looking high level, and this is purely from a plan design contribution perspective, how many options do these other employers offer versus Brevard? Brevard, as I'm sure fully well aware, has one medical plan. You can vary your cost shares based on wellness participation within that plan, but employees buy one plan, that's the one plan they pay the contribution for. You can see that basically of this group, 20% have one plan like you all, 80% offer a choice, and they offer 3 or 4. That's the prevalent practice out there. In terms of the mix of plans, you can see what the other employers, entities offer. You all offer a PPO. That's the dominant plan design out there. 80% offer a PPO, but you can see what some of the other options are that are offered by these employers. This next row is how does the district, how does the board subsidize the premium of the plan? And what Brevard does is they have a dollar contribution towards single coverage and they have a dollar contribution toward family coverage. What you'll see, and I see this beyond this peer group with other clients that Florida school districts that I work with, 80% of this group basically have $1 amount that goes toward single coverage, and that same dollar amount goes toward family coverage. So a little bit different approach to how the cost sharing is set up. And then something that is also a little different is 70% of these other entities have at least one plan with no contribution for single coverage. And you all have a contribution for single and a contribution for family coverage. So, and these two tend to go hand in hand with what some other employers are doing, where this flat dollar that they apply really results in that no contribution for that single coverage.
When you looked at this peer group, did you consider what shape that their health plan is in? For instance, Polk County had major issues with their health plan, and Volusia is fully insured and not self-insured. So, we could be comparing to some of these options, and they're not good options to be looking at.
Yeah. Correct me if I'm wrong, Jonathan. I think this group was selected because this is a group that I think Brevard, from maybe a talent and a size perspective, may look to in terms of a competitor type district or a like entity, and that's how this group was looked at. There was no paying attention to funding or health of the health fund or anything like that. It was purely
We just looked at districts that are similar to our size and those that surround us. So that's what that comparison is. And actually, this is just a summary. Each one of those is listed on the next page and in the appendix. So you can see how those plans are made up and what the contribution rate is, what co-payments, deductibles, and all of those are. This was just two of those in detail. If you look in the appendix, the rest of them are listed there, so you can see where the comparisons are.
And that was going to be my next question. Why are we highlighting those two?
We're just giving, Paul was just going to go over the summary of what those are and how you could read these charts. But we can certainly look at any one of them. It's just, we had so many to go through, we didn't want to go through every single one. The first two slides were just a summary, and that is correct, Jonathan?
correct.
Yeah.
We just built two, so Nadia, you gotta take
Can I
us
ask
through.
one quick question?
Sure.
And maybe this is like a change in the market trend, but when we had Willis Towers Watson, the high deductible health plans, they said that almost every plan that they had in the government sector had that as an option. And you guys are saying only 20%. So is that a change? Did you used to have more, and now it's only 20, or just your clients are not picking that option, or what?
I can't speak to their benchmark or who they were comparing you against. I would say outside of public sector, that is a more prevalent plan design. But within public sector, in particular these peers, that's what they're offering.
You may not know this, but do we have any idea of of those other districts, what percent of their employees choose this high with HDH?
High deductible health plan.
Thank you.
I think we have
Yes.
some of them.
Yeah, we did request it from each of the school districts. We got from some, so those are noted. Any ones that are in yellow, like.
It's on the chart,
Yes,
saying on the.
we haven't received the information for yet.
Like we have it for Lee County, but not for Brevard County.
Yes, we did request it. We haven't received it. When we do receive, we'll update the chart. But quickly, we've got Brevard Public Schools on the right. To the left would be the peer. And we chose Brevard County Board of Commissioners because they're local. So you'll see that they have 3 plans. We've chosen their PPO plan to compare against your current OAP plan because it's the most similar. They also have a wellness and non-wellness component of their annual deductible, but even with theirs, your in-network deductible is still lower, so you have that lower option for employees. You'll see that you have red, green, blue text. The red would be means that the peer group has a higher member cost share. Anything in green means it's a lower member cost share. It means when they go to the doctor or the pharmacy, they're gonna pay lower than what your members would pay. Anything in blue would just depend on the service that is provided. So it could be lower, or it could be higher, or it could be about the same. And then, so again, highlighted in, well, shaded in gray is the one that the plan that we're comparing against. And, like Jonathan said, your wellness component is a better cost share for your members. Then the second we chose to do, they have 4 plans. So here we were able to get the enrollment per plan. So you'll see that their high deductible, which is their HSA plan, does have 450 employees that are enrolled. They don't have a wellness component to their plans, but we did choose their middle plan there, the 5773 plan, to compare. And as you'll look down, it's pretty much, their plan is a higher member cost share. That's what you'll see all in red. You'll have in blue the emergency room. Theirs is $500, whereas yours, you have a copay plus a co-insurance. So it could be lower or higher just depending on what their what your members' co-insurance would be. You'll notice that for their pharmacy, they do offer an out-of-network, so we did put that in green because they do have that. But still, your members, you want to stay in network because they do get a lower cost share when you stay in network. I know I went through that quickly, but
Yeah, just a couple points I'll point out, which I think is important to understand, is that as Nadia had mentioned, they offer other plans, and they offer other plans at certain price points. Some will do a flat contribution, and some will do a mixed tier contribution. So when you look at the benchmarking that we did, you have to realize that there are different price points that the employee can choose. So it's a choice model. It's a choice whether I take a higher deductible and take the risk myself and leverage potentially other options as telemedicine would be at $0. I can leverage that. If there's a clinic there, they can use the clinic as well. So when you look at some of the other districts, as Paul had mentioned, they've moved to more of a choice model and put price points at different levels for people to choose from. Because the 25-year-old teacher or administrative person may want something different than a 55-year-old teacher that's here at the district. And that is, again, why you see the changes as far as what's out of pocket to people and what their costs are. And it's pretty important to kind of understand the bigger picture. As you know, there's a lot of moving parts here. It's just not, here's a plan, here's the benefit, here's the price. It could be, here's 4 plans, here's 4 prices. And depending on your design, people may choose the lowest cost, or they may choose something in the middle, or something with copays.
But this would be an example of a district or employer whose their contribution is flat. So
that's correct.
Whether you are just insuring yourself or insuring your whole family, they're only paying that flat, whatever, $613 or $583 per employee.
Right. And what's unique about this particular one as well is that they're with a competitor of Cigna's that has actually clinics now that can be integrated into the program. So they're using that particular model a little differently this year. So they have access to care at a $0 cost for telemedicine and behavioral health, and then they have access to the clinics, and then they have access to the providers in the community. So everybody's kind of picking a different approach.
I do want to emphasize, though, all of the districts that the comparative are listed in the appendix.
Yes, thank you.
So if you want to look at all of the other districts that
that's probably 10
pages. It's important that you look in that area as well. They're all in the appendix.
Can I ask a quick question? Can you guys go back one slide, please? So when I look at that, we have the Cigna OAP plan and the county has the Cigna OAP plan. And that's the two that you have compared and identified better, worse, unable to necessarily define, right?
Mm-hmm.
Why is it that we both have Cigna plans and yet you're indicating that some aspects of the Cigna plan in the county is better than aspects of our Cigna plan? Are you actually comparing, are we comparing apples for apples there, or are we comparing apples to oranges? Because it seems to, I know there's gonna be variations within plan, but I feel like you're saying they have better benefit in this area when in truth that may not be the case. Does that make sense?
The question I think I do understand. So I would just say under like an annual out-of-pocket, where yours is 4,000, 8,000 under the medical component, theirs is 2,000, 4,000, which is better, so it's green, right? And then the other components where the inpatient hospital, there's 20% after the deductible and $600 copay. Theirs is just purely 20% after deductible. So again, better benefit, better plan design. I think that's pretty consistent down the road. Does that make sense?
But only if you use it, right? It's not indicative of, I think my concern is that it almost seems as though it's being presented that our employees have less benefit, that they're paying more. When in fact, if they're not utilizing those services and they're getting more benefit in another place, do you see what I'm saying? The perception around it makes it seem as though they're, okay, for example, they're out of pocket. Well, if I never hit the out of pocket maximum and I'm paying lower premiums than they're paying next door,
Right.
I'm getting more benefit out of my plan because I haven't hit the out of pocket maximum.
Right. But when we compare, I mean, we do benchmarking to benchmarking, so we compare plan to plan. We can't get Brevard County Board of County Commission to give us the breakdown of the spend by plan, by deductible, by co-insurance, by age, graphic. So this is kind of like the best that we can compare benchmarks to plan. As you can see, it's a little, it's complicated, right? As far as a lot of components. But I think what's critical to take away is there's not, I don't see any major, outliers from a benefit design perspective. And so I think that's important. As I mentioned earlier, the clinic model gives a lot of access to care, and you have a telemedicine solution set that you can call for no cost as well.
See, I think that's a critical component because the WellCare centers, there is no copay or deductible for treatment or pharmacy if it's dispensed in the clinic. So that's something that we really need to pay attention to, even though they might show, what is the copay? $30 for primary care, we're $30. But when you figure in what that would cost if you went to the clinic, we're actually paying less than that. In my mind, that should be green, but because we're comparing apples to apples, it wouldn't show that. You see what I'm saying? So I think that's an important component because our employees are getting the benefit of that. The clinic is a great option.
Yeah, so the purpose of the first part of this obviously has just been to set the level of the data. These are the facts that we have, this is the data that we have, and this is where the district, stands. And then the next piece, we're gonna go into the financial overview. Okay.
Mark, let me ask you a question. Is it true that we used to have choices in plans years ago?
We did.
Okay, so why did we get rid of that? What happened? Something happened.
Well, that was, there's probably people sitting in here that have a better idea because they were on Siac. It's my understanding at the time, because this was before I came in. We had multiple plans, but what was happening is our costs were increasing to the point where the state said you can no longer be self-insured because we didn't have enough money in our 60-day reserve, right? So the decision of the Siac at that time was to quash all of those plans into one plan. And that's where we are right now. We haven't changed that model since 2014.
It's economy of scale. We were in a pinch, and the state was saying we had to infuse money. So what they did was they went down to one plan to be able to better monitor and to be able to utilize all of the medical plans and stuff at a better utilization rate under one house.
Okay,
Right, so then the concern is if we open it back up, which I would like for us to do, but if we open back up to more than one plan, are we at risk of?
Well, it just depended on the
coming in?
plans because they were similar plans in design of what we have currently. Depends on the plan. If you go to a preferred network or an alternative network or something, those were never options that were available at the time.
Right.
So if we are talking, it's apples to oranges.
It also goes to how you price the plans too,
Yes.
because you will invoke some adverse selection because those that are higher utilizers will migrate to the plan with the most benefits. So if you don't price it right, you're going to cause a worse problem.
And so
I'm not saying choice isn't a good thing. Right. It has to be done right. Because if you miss this mark,
yeah, so you
think
have
you got
to know
problems
the
now, you're going to
contribution,
have worse problems.
Contribution, the benefit, And then that's where Amanda Brooke Cross comes into play, where she does all the analysis on where we expect people to land based on the whole package. You know, it can't be fragmented in pieces. It has to all work together. Whether it's a benefit design, whether it's a contribution, whether it's multiple plans, whether how you manage the clinic, etc. So we have to put this puzzle together with all the pieces, not just one solution set.
And you need to add margin because you probably will not get it exactly right.
Exactly. I mean, that's in that situation, we would definitely test migration. We would do expected migration based on the pricing, but we would definitely run a lot of scenarios around the sensitivity of that migration and what's the financial impact of that. Because when you offer one plan, you know what the revenue is going to be from employees. But when you offer multiple plans, depending on where people land that revenue is going to vary. So.
And that goes back to your communication strategy and how you educate people and engage them. So I just want to stick with time. Are we good with the benchmarking piece?
We will end there and move on to
all right,
financial
thank
report.
you.
Bonnie, would you come up?
Okay. For those of you who don't know, my name is Bonnie Dawson. I work with North Vanderbilt. This is our retained earnings statement for calendar year 2019. As we expected and as we looked at all year, the revenue for each of the quarters are running flat because we haven't made any changes to our premiums. It looks like in quarter 2 and quarter 3, there's a variance there, but it's because, as we mentioned before, it's because the accrual started in June and reversed out in quarter 3 in July. If you average those 2 quarters together, you'll see it's about $16 million, which runs flat to the rest of the quarters for the year. When you look at the expenses, if you look at total administrative costs, you'll see in quarter 3 it looks a little low there. And the reason there is we had 2 months of the Cigna admin holidays included in there, which was around $400,000. So that's why our admin costs look low there. All the rest looks pretty flat, except for in quarter 3, pharmacy and medical are a little high, and the reason for that is that's the summer months, and when the teachers are out, they tend to go to the doctor and get their business taken care of during the summer. So that's why those numbers are a little bit higher. End result is we ran a $4.8 million loss for the year. Our fund balance is $9.2 million, and as of June of next year, we're going to need to have $11.8 million to meet the Department of Insurance's requirement. So you can see that as of the end of the year, we're about $2.5 million shy.
I just wanted to interject something here. Since I've been on this committee, I've been hearing the doomsday scenario the whole entire time I've been on the committee. So I went back and looked at some projections as far back as I could find, which was in May 2018. We were projected to be between 4.7 million and 12.1 million deficit by 2020. The actual deficit is 2.4 million, and by June 2020, it's going to be 1.2. So these projections are based on our history here in this committee, are doomsday projections. And what if we would have overreacted at that time? And I got to say, our previous CFO, one thing she did right was not fall for those doomsday predictions, and pointed out that they are just that, projections, and they have not been historically accurate. So we need to keep that in mind. I mean, because that's why we are here, is because of the fund balance, or the projected fund balance. So, are we looking at the doomsday scenario, or is this, the real deal, based on the history.
Or is it not as bad as it would have been because of the changes that have been made in the last?
When have we given enough time for those changes to go into effect? So that's why I go back to my, how I started the meeting. What are we looking to do? Get through June or make massive changes going forward for years to come? There's always a lot of questions on this committee, questions that sometimes are unanswered. Do we, perhaps rush into major changes, but, quickly by June, or just get through and allow time to work out kinks, find some more information, and get some answers?
Thank you.
Okay, just to clarify, these are actual numbers, these are not
Yes.
projections.
I know.
But in a couple of slides, you will see projections,
Right.
and then we'll come up and she will be talking about that very thing. Okay. So this is just to give you an idea of how we've worked from 2010 to 2019. And when you look at the revenue, you'll see that it's flat amongst years until you get to 2015. In 2015, we made a lot of changes to our plan. We changed the plan design, we increased the premiums for the board and the employee, and we also moved our retirees to the consortium at that time. So that's why there's a difference in premiums, and also you'll see a difference in increase and decrease in plan operations. If you go ahead and look at the bottom line, increase and decrease in plan operations, that's how the plan is running. So you can see throughout the years, we were not ever really holding our own, except for when we made the big changes, and you can see in 15 and 16, we were holding our own because of the plan design changes. But now, 17, 18, 19, we're back into not holding our own again. And it is true, in the past, we did get infusions from the general fund. You see the yellow line are the infusions that we received, and the Department of Insurance was fine with that. They said, oh, as long as you can cover it, we're fine. But the last letters that we received from them, they said, and I think there was a change, Amanda, didn't say there was a change in their management or whatever.
Yes.
They're not going to accept that anymore. So they said, you're going to have to hold your own, or you can't be self-funded anymore. So, it is important that we are able to run our own without borrowing money from the general fund all the time to bail us out.
Do we know what happened between 16 and 17 for the under medical, 10 million, 45 to 52?
Are you talking about medical expense?
Yes, ma'am. Well, and even across the board, pharmacy
Yeah.
goes up a
So,
million, everything,
and
what
that's
happened between
a
16
good
and
point,
17?
because you see, that's like the only expense that's really gone up from 44 to
That's when we added the clinics.
So, well,
The
that's,
clinics are listed.
the clinics are separate, the clinics are added separate, so you can see that that's really our only expense that's going up.
It's medical class, and it's, from what we've seen in prior reports, it's the chronic medical conditions that are costing us the most money. Those people would have one or more chronic conditions.
Right. So
They're
it's
the
not,
ones that are incurring it.
it's not the pharmacy pretty much is flat all along, so it isn't the pharmacy that's going up, it's the medical claims that are going up.
We spent a lot of time on pharmacy initially, but if you look, and I just want to point this out because I think this is important. In 2010, we spent $10 million on pharmacy, but when you did do that based on the total cost of medical, and then you compare that to where we are now, we're actually spending less on pharmacy than we were 10 years ago as a percentage of the total cost of medical. Because our total cost of medical this past year was $72 million, and we're spending about 10.7. So when you look at the percentage, we're actually spending less on pharmacy. And you have to figure over a 10-year period, pricing on pharmacy has increased every single year. We just got notified that 500 drugs are going to be going up as of January 1. The great thing is we have been making some changes. And if you look here on 14, you can see where our pharmacy spend was at that point, at $12.8 million. We did make some changes, We've continued to make additional changes, including the changes we made in April, which I think is helping us from the increase that happened last year. So if you look at that, we had 11.1 million in 17, we're now down to 10.7. So our pharmacy is in good shape from my view.
And does this include the rebates?
Yes.
This does include the rebates, and I was going to mention that to you also. I have a report here that shows what the rebates were in 2013, and they were 103,000. In 2019, they were 2.8 million. So every year, the rebates have increasingly gone up.
I do want to point something out that I think is important as well. If you look at the administrative cost line, and you compare where we were in 2010, we spent 4.9 million on administrative costs. Now that cost is what we pay for Cigna. It includes the staff here in the Viera, that is included in that cost. We were at $4.9 million 10 years ago, and look where we were last year, 3.4 million. So our cost to adjudicate those claims has actually gone down by 1.4 million over a 10-year period. So as far as the administration, pharmacy, those are looking better. What's killing us from a cost perspective is the medical, and you can see that last year we were at 51 million, this year we're at 54 and a half.
And the increase in the clinics just keeps going up too, and it's not making the medical go down. It's making medical keeps climbing too, I think. And $10 million in 3 years, plus $3 million now in clinics. That just seems.
Is there any? I'm sorry. That's okay. Go ahead.
Madam Chair, thank you. So just a real quick comment about pharmacy. In the past 24 to, 36 months, we've had some major expensive drugs go generic. So I wouldn't necessarily say that we should be really happy because our pharmacy costs are going down. I mean, honestly, I think they should be less than this. We have about a 15% on pharmacy to total cost of the plan. There are some data out there that shows that pharmacy is 9.5% of total healthcare cost in a whole pie. So I'm just kind of pointing that out. That I sat down with Penny when she was like doing the balloon on some things. I said, we've got 5 drugs that are going generic, in the next 6 months. So our pharmacy cost should be going down because instead of something costing $1,200 a month, now it costs $35. So, I mean, there's substantial differences there.
Why there any? Oh, sorry. That's right. Go ahead.
Why in 2015 was pharmacy only 8 million? I mean, it's gone up 2 million.
Well,
It's an anomaly year.
in 2015, we also moved our retirees off our plan. And
But then we managed to climb another 2 million. So we moved them off, hooray. You go down
But
to 4
is
million.
that some of that just the cost, healthcare over the last, just nationally?
Why? That's the question. Can we fix something within our system?
We can't fix the national healthcare,
So people say it's not the healthcare that's expensive, it's the charges. So those are kind of some things that we have been trying to drill down in the Siac.
Is there any coordination between Cigna and our clinics? And by that I mean, is Cigna driving people to utilize our clinics when they find out that they have chronic health issues? Are they encouraging them to work with our clinic folks to help them address that? Is there any, or are you guys working in complete separate silos?
They are working together. Oh, if I can speak to that.
To what extent?
We have the Cigna RN health coach and the Marathon health coach working together on getting people to coach with a physician. They both work in tandem when a biometric is done, and they're encouraging them to go to the Marathon Health Clinic in order to deal with their chronic conditions. So they are working together on those things. Both RN health coaches work together every time somebody walks in the door to do a biometric, and after each visit, they're doing their best. Not everybody will listen to them, but everybody, they're trying to read those numbers and make the recommendation that they treat with one of the providers in the clinic. That's happening almost every visit when it comes to biometrics.
Mark, but haven't we been told year after year that this like the jump between 16 and 17 in medical, that $7 million jump, that's not because of chronics, that's because of catastrophics.
Yes.
Right.
So we need to be careful that catastrophics aren't going to go to the clinic.
Right.
If your child's got cancer, That's what's killing us, is the
10% of your,
catastrophics.
or 10% of your population is costing you 90%. So the focus, a paradigm shift, is not in the 80%, the 90% of the population that's starting to use the wellness clinics, that's using Teladoc, that as education continues, will continue to improve all of those types of statistics. The solutions lie in focusing in on that 10%, and how do we do that? To your comment on, you know, what drives healthcare are the costs. And so in building, is it setting up more wellness clinics when in fact, how do we build the benefits and use the resources that Cigna and Aon have in focusing in on reining in the costs for that smaller segment of the population that actually impacts everybody.
Right, and another clinic's not gonna do
Another
anything to
clinic's
that.
not
It's
gonna
gonna
solve
phase
that.
No.
As nice as that would be, but with the expenses that we're faced with, what are the solutions? And the focus is on that, should be on that 10%, that 1%, as opposed to the 90.
And in doing so, you focus on your specialty drugs, your on all of your procedures and everything else, and steer them towards the lower cost centers because they are the highest amount of our insurance cost. Exactly.
My concern is that even when we talk about, you know, if we can negotiate, you know, costs with providers and things like that, some of those catastrophic they are necessarily having to go outside of the county. They're having to go to the Arnold Palmer, right? And which, that's not anything that we can negotiate with Health First and Parish.
But those centers of excellence are still within the networks, and so as part of the solutions that, you know, we have bantered about in, you know, nearer networks, but whenever you get into catastrophic care, you can probably, you know, speak much more eloquently than I can on how that care management ensues.
So Sheila, let me ask you, so, you know, the solutions that we've been talking about, like narrow networks, I mean, personally,
alternative network. Can we say alternative?
I don't feel like that, you know, we're saying it's these folks that are causing the problem, so to speak, right? But we're going to go to the narrow network, and it seems to...
So I'm not necessarily in agreement with that.
Right,
what
well,
I'm saying
what I'm
is
trying to
we're
ask
talking
you
about a lot of
is
things that...
how do you target those folks? Because it seems like we're targeting our healthy folks, not our sick folks. And, you know, it seems like what we've been doing, and part of the well care centers, not catastrophic, but, you know, chronic, is not working. So how do we target those folks without taking it out on the healthy employees?
Or even the chronic employees.
Or the employees like myself, who only visit the doctor every 3 or 4 years, and are willing to go to an alternative network because of the cost being lower, in the fact that I may not need as many doctor's offices and stuff like that. And that would save the actual plan in the event that I'm going to do different procedures throughout in case something happens. Do you see what I mean? So there's a win-win on both sides when you target those high cost areas, but then you also allow some of the underutilized individuals on the plan to take advantage of alternative networks.
So you're telling me that the huge increase is from catastrophic and some chronic, is that right?
I'm saying, when you look at the presentation of the claims, which was from last month, I believe, and Cigna and Aon should probably respond to that better than I, but it follows the old 80-20, 90-10 rule clearly within our school system, that 10% of your population is what's driving 90% of your costs.
And it was even less than that. I remember
It
distinctly,
was.
it was like 11 people. 11 people are...
And those catastrophic people are not going to our health clinics.
No. These are people with really
Health
advanced
people with more than $100,000 worth of
What
claims.
I'm saying is for this, 2019, we've now put $3.1 million into these health clinics, and it's not touched. Our medical costs are still going up. It's like an addition.
I don't know if you can make that correlation,
Yeah.
because I think at some level you have to say there is some that it's bended the trend curve. Because if you didn't have the clinics, a lot of that other care would be done elsewhere at probably higher cost facilities. So the number could be worse. Now, can you directly correlate that cost to the clinics? I'm not sure that math can be done exactly unless you take every code that was done in that clinic and put it out in the, in the private sector.
I wonder how much of it, I know people in this room probably aren't gonna like this too much, but it's just me thinking out loud. If you shut down clinics, does 3.1 million now get put towards that bottom line of 4.8 and we now don't have as
No,
much?
because that care goes somewhere
No, that
else.
care is gonna go into a different
That-
facility,
that adds
which is
into our
typically going to be
pharmacy.
higher cost.
Well, there were some studies about retail clinics to show that when there was no, and this was like when Walgreens was getting into that and CVS was getting into it. So when you had no copay for these retail clinics, your utilization kind of skyrocketed with no better outcome. So, I mean, to Tina's point, we don't really know. I mean, we're kind of projecting and hoping that, there might be people that like going to the clinics, because it's free and they're high utilizers and they don't need to be. I mean, we don't know that necessarily.
You said consults, they're talking about long-term health. I'm not suggesting this, and I know I throw it out there, people are panicking, but, and I know it wouldn't take 3 million away, period. I know that. I know you're gonna get some cost there, but I wonder how much savings is there. Because I'm still concerned about the one chart where he said we had the difference and never took into account people knowing the other doctors and what that cost is. I feel like a lot of these numbers are just fungible numbers, and it's a little frustrating to make such huge decisions on numbers that the data may not be so great.
And may I add, I know Mark, and I don't mean to say this to contradict what you were saying earlier, but you're mentioning that over the whole period, that the major driver has been medical, not pharmacy. But if you look at the major changes that were made in 15 and look at that data going forward, and I think a couple of us, somebody else in here mentioned this, but looking at the actual percentage change, I calculated real quick, this pharmacies went up by 25% from 2015 to 2019, whereas medical has only went up by 14%.
And medical should.
Well, I had to calculate that, but just using the data she has there, because in 15, I'm on page 45, one sub.
And you're going from.
2015, where it's
mine says,
8.6.
Yeah, mine says 45 too.
Mine says 45, so. Yeah, I noticed that earlier.
What I was talking about is the
731
percentage of
trust.
total medical spend. So if you look, 15 was an anomaly. We had a very good year from a pharmaceutical standpoint. I don't think we really know or understand why it's 2 million less than what we paid the year after that. But if you're looking at, you take that number divided by the total medical spend and compare it that year to where we are now at 72 million, it may be about similar between 15 and 19, but for the other years in between, our percentage of pharmacy spend is actually lower when you figure that out as of the total cost of medical spend.
Dawn said it should have been around 9.5. I have no idea where you got that number from. Is that
I'll find the chart
an
and
industry
send it.
standard?
Yeah,
If that's the
that looks
industry
right.
standard, then we're blowing that out of the water.
That's just national across the whole country.
So, can I ask a quick question? When I'm looking at the pharmacy and it has the 11 million, the 10 million, the 10 million, that is the cost to our plan per year minus what the co-pays are, minus what we're receiving in rebates and everything else. Is that true? Is that number?
This is what we actually paid
Yep.
for pharmacy.
Right, so that's after the spend. So where the anomaly that we may need to take a look at is that Cigna has given back to us 2.7, 1 point, and you're looking at numbers that are including rebates and everything else. So if you're looking at a true trend rate and true spend rate, that's not the number that you're looking at. That's what we spent, granted. But when you're looking at prescription fills and when you're looking at all of those things, it's a completely different number. The other thing is that we're moving a lot, there's a lot of cost shifts towards generics. Generics have a higher copay send-off towards our workers than we have. So for instance, if you have a generic pill that's a $3.83, our plan doesn't pick that up because the copay covers that. So as we move to generics, the other anomaly that's occurring is that the plan is actually spending more or the same on a less number of drugs as our individuals are paying more over here with the copays. And that's good for the overall plan and good for the people because we're moving to generics and it is causing less, and it might be an actual less money because the copay for a non-generic is going to be more and everything else. But I want those two anomalies to be remembered. In that we're looking at two different data sets that are moving through the pharmacy that we may want to keep an eye on too. That's all. Good and bad. I'm just
That
saying.
would be an interesting percentage to find out is what percent of the pharmacy claims actually the plan pays nothing on.
It's easy to extrapolate from the data we have. Okay. Yeah.
So getting back around to it then, and even including catastrophic, the last time we met, it was 3.2% of the employees and dependents were accounting for 52 to 53% of the money spent. As far as answering the question about cancer care, what we had done here for 12 years, and actually beyond that, because now it's more like 19, we will send the patient to Moffitt or to Mayo. They tell us what the plan is. The care takes place back here. And that's what should happen. And the same thing is true for tertiary. We can't do it here. The procedure, whatever it is, gets done, but the follow-on care, the patient is transferred back so that you have, once again, the lowest cost. But the other part of it too is you're in your support system, your family's here, everything else is here. And it's going to make it a lot easier. So if we look at it then, what's the plan, whether it's through the clinic or some other method, then if it's 378 people, how do we connect with them? How do we manage them? Because that's the key here is we're not really managing care to the degree that we should be to actually achieve the best result.
And can we do that because of FERPA? Can we identify who those people are?
Cigna, some of the stats that we didn't include in this because we're trying to get through a lot of information and didn't get down in the weeds, basically, shows the number of people who are participating in Cigna's quality care programs. Brian, do you have that right off the top
Well,
of
we
your
have
head?
about 56% of the people are engaged in the programs, and to the extent that catastrophic claims are going to have some that you really can't impact. You're going to have the car accidents, the motorcycle accidents, NICU, babies that are premature. There's some you're not going to be able to manage at all initially before they happen. But I still think you need to hit the 80% or 90% to get them in these programs and make sure they don't become a catastrophic claim. Those that don't go to the doctor at all, probably 90% of your population never goes to the doctor. You need to get them to go and get some of their preventive care done so that they don't become catastrophic. And if you go from the 44.5 million in 2010 in medical up to about 54.5 million, it's 22% increase over 10 years. That's a 2% increase.
Not bad.
Annually, that's excellent. And if you just raise premiums just 2% a year, you wouldn't have this situation now. The way I look at it, I know that's probably not a popular thing to say.
People did not shoot you.
Everyone that hasn't raised premiums at least a little bit, maybe a few years they went by without raising premiums, but typically if you raise the premiums 2 to 3% a year, would be in pretty good shape.
We have gone 6 years without a premium increase, which is affecting where we are right now.
So we've raised deductibles, we've raised other things that the ones that are actually using the medical plan, they're paying it instead of premium increases for the people that aren't using it.
So I'd like to say something to that, in that I holistically understand that we have done a great job on our plan over the years in controlling the majority of costs. You can show a 2% trend rate is amazing. But there is still opportunity to save more. And I think where my argument for me as an individual is that although I understand that we should have done this and we should have done that, there is an opportunity to save. And when we were talking about whether we have those car accidents and those cancers and everything else, it's from the point of service on that we may be able to save something. And that deals with some of the surgeries, the surgical procedures that we're doing and curbing the cost and sending them to the right lower cost and better cost options. So I understand that we've been doing a good job, but I don't think that stops there to just say, okay, this is good enough for us. I think we continue to push to get as good as we can. And I've always done that in everything that I've done. So I understand that we've done it low, we've had a low rate, but at the same time, we can do better. And I think we can. And I don't think we should stop there at the 2%. Let's show the rest of the state what we can do. Thank you.
I do want to say, and Lisa's going to talk about the communication plans that we have put out over the years. I think our participation has improved. I certainly get more people contacting me by email because I send out a monthly spotlight on benefits and some of the other things that we do. Cigna does reach out by telephone. And what you were saying was correct earlier. We do not have protected health information. So my team cannot reach out to the individual and say, look, we have this going on. So we utilize Cigna to help us with that. They do reach out to people by telephone. If they're not able to get through by telephone, they send them letters. They're doing what they can to communicate with them. There will always be people who won't respond to those. And I've heard this committee say that to me several times, because they say they're getting inundated by letters and telephone calls, they don't even want to respond to it. We're looking for any help we can have, from this committee. If there's a way to do it, that's what we want to look into. But those are the things that they are doing. 56 is low compared, I don't know, how does that compare to other districts?
Actually, compared to the norm for state of, I'm Corey with Signal Engagement Consultants, and question will not quite bit of information. But for the state of Florida school boards, the norm is 34%, and you guys are at 57%. And when, was it Dave, so when he qualified engagement, he said it was one visit with face-to-face with a doctor. We look at two different aspects. So I love, you are absolutely correct, usually 10 to 20% of any plan is driving most of your costs. There's really three tiers you need to look at, right? You have your healthy people that you want to keep healthy. You have the people that have a chronic condition that are not catastrophic, that you're trying to maintain or improve, and then you have your catastrophic. Important part for the people that are healthy, you need to detect problems, like Ryan said, before they become an issue. So that is with that preventative health care, and that's part of what Marathon is there for. And yes, to Mark's point, we do work in collaboration with that, but there is a lot of outreach that we do on behalf, based on the information that we receive from claims, as well as the health assessment. We're able to see self-reported data, so maybe someone didn't go to the doctor, but they did go in and answer some questions about some of their health information from the biometrics. We capture that and qualify them as low risk, middle risk, or high risk. And depending on that risk level, we're either reaching out via phone call if it's a more higher risk. So if you got a phone call, then I guess you could say that you're a higher risk, or you're going for treatment for some type of condition or procedure where we're trying to help you direct you to the best type of care and help you manage that care. I think the number was like 5,600 on that report, I would say. So that we're reaching out to already to help manage a type of condition or get them into coaching programs and direct them to care to help manage a condition. And then the engagement, there's two aspects. So people that are healthy is called health maintenance. They have to do two types of health engagement activities to count as engaged. So whether that is if they went to get their preventive checkup, if they did not also do their health assessment, they don't count as engaged. If they did their biometrics, but then they also entered a coaching program because they were recommended for that, they then count for engaged. Health improvement is a smaller bucket. These are people that have a type of issue or treatment that they're dealing with. This is always going to be a lower number. You guys are actually higher. I want to say around 7%, but norm is usually around 3 to 4%. So they're taking those two combined buckets of the health maintenance and the health improvement, and that's where you're seeing the combined 57%. Sorry, I wanted to say that earlier, but I didn't remember.
All right. We're running pretty close on time, and we want additional discussion to what we've already had. So, Amanda, would you go through what's your projection?
Yes. Okay, so first, I want to orient you to this and why we break this out in 6-month segments. So your plan year is on the calendar year. And as you know, your fiscal year runs 7/1 to 6/30. The state measures your fund on the fiscal year basis. So we want to show you what the numbers look like on a fiscal year basis, but also on a plan year basis. The other reason to break this out differently is because on the revenue side, 7 months of premiums are received in the first 6 months of the year. So July premiums, we talked about this in Siac, but some of you haven't been here for that. The July premiums are paid in June due to the structure and nature of being a school district. So when you're looking at this, things look a little bit skewed. It's not even. I think if you're looking at 6-month segments, the losses in the first half of the year would be similar to the second half. That's not the case here because you're getting 7 months of premium in the first half, only 5 months of premium in the second half, but you're receiving monthly expenses throughout the year. So to orient you to the slide, so we're starting off with Bonnie's data that she talked about earlier. The current fund balance at the end of December was $9.2 million. The required fund balance, this is from the state's 11208 requirement, is $11.6 million at that measurement date, which is 60 days of claims, including the clinic. So at that measurement point in time, it's 2.5 million below the safe harbor. Now the state is not looking at that today. They won't look at that again until June. That filing isn't done until September. So then we would project that forward. So I want to be clear about when we're doing the projections here, because we're showing 2 years of projections. So for 2020 projections, we are using, and we footnoted it at the bottom of the slides, what we're using for trends. So for medical trend, we are assuming 6% in 2020, 6.4% for pharmacy. This is based on our Aon Trend Survey and the data we gather. We have a whole team that works together to develop projected trend rates. And then for 2021, it's slightly different, 6% still for medical, 6.9% for pharmacy. So those are the claim projections going forward.
Can I ask a question? So these projections aren't based on the last 5 years of actual trend for BPS, but, you know, like national trends or peer group trends or whatever?
Correct, because on an individual basis, the volatility of trend, you can have good years, you can have bad years. And so what we do on a projected basis is take what is expected on average. So we certainly hope it comes in less than that. It may come in higher than that. Throughout all of our clients, we have some that have good years, some that have bad years. But this is the expected trend.
Have we had a 6% trend in medical or 6.4 in pharmacy increase in the last 5 years?
Yeah, look at 18 to 19 in medical.
What
right at 6%.
What slide are you looking at?
I'm just looking at 45. Take 54 million divided by 51, you come up with 6%. Take the medical spend. Take 54, 510, 904 divided by 51, 232, 056, you'll come up with 6%.
But that's just 1 year. But over time,
I understand, but the other thing you
got
got to factor in is not just trend, but innovation. Okay, right? It's not just what the doctor's getting paid more for, but it's the new procedures he's doing, the new technology that's coming online. So trend encompasses a lot more than just what the doctor's getting paid for what he's doing currently. Remember, there's innovation that comes into this thing.
And also, the percentages are not listed here, but back on slide 5 that we started back at the beginning has the history back to 2010 for your total expenses. So it's not just claims, but obviously claims are the majority. And you can see that the dollars are there, so the percentages could be calculated. But you can see the light blue line where it goes up a little bit, goes down a little bit, goes up a little bit more, stays flat, goes up. So you do see that volatility over time.
Can you go back to just real quick, you said beginning 2020 fund balance, moving forward, you had what percentage of medical and what percentage of pharmacy?
The trend
yes, the trend rate, sorry.
So it's 6% for medical for 2020, 6.4% for pharmacy. 2021 is 6% for medical and 6.9% for pharmacy.
And those aren't based on a 5 to 10 year trend of our own, which is what we argued, but are doable to the trend rates of the national and possibly 1 or 2 of our previous years that we actually had. Okay.
Excuse me, I'd like to just comment, kind of be a contrarian to you, Mike. I'm reading a lot of stuff. I mean, just accepting medical costs go up every year, medical costs go up every year, medical costs go up every year. I mean, look at what happened in the state of Montana when Marilyn Bartlett took over and they went from a deficit to $100 million in surplus. They had so much money in surplus, they had to pass a law of what they could do with it because they've never had that much money in Montana before. So as a group here...
Did they go reference-based pricing? Okay, so I don't think we can compare a state that went reference-based pricing to, again, that would be us going to an extreme measure to say that we could do the same thing.
Well, I personally think we're at an extreme time here. Because one of the recommendations, again, is going up on premiums on employees who, are complaining now about salaries still. So we are at the time that if we don't change our thinking some, then we're just gonna accept this every year, 6.5%, 6.5%, 6.5%. And it's not like this all over the place 100% of the time. So I'm just kind of putting it
Well,
out
I mean,
there.
it's an extreme measure that you could look at. You could also say, Anthony, I think, is going to have an issue when he starts getting complaints about balanced billing coming in from providers saying, your plan's not paying because we're not
That was
accepting Medicare.
one example, I'm just kind of putting it
No,
out there.
I hear you. I think it's a little of everything that needs to be done here. I mean, I think we've been very static in what we have done. I mean, Chris and I have been on here, since 4 years now? And again, we've done some changes. I think we've been very good at beating down the vendors. I mean, I think we've renegotiated the fixed fee costs a lot. I think we've done some good things to get Cigna some premium holidays. I think sooner or later, we're going to run out of those places we can squeeze, and we're going to have to do more traditional measures, which are plan design changes and employee contributions and board contributions. I think we're going to get to that point. I would say that there's been an exceptional job done of managing the costs by, non-traditional means, which is what you want to do, which is what I think everybody here is saying, let's cut the fat out of this thing. Let's make this thing run as efficiently as possible. Sooner or later, you're running out of runway on this thing because you're fighting a trend that goes up. And I don't know, what is it, every year you guys are renegotiating with pretty much every provider out there, and they want more money because their expenses are going up. I mean, network management can tell you what they're fighting in cost there. So, again, there are extreme measures we could leverage. Those have, secondary and tertiary impacts on how the people are going to perceive those.
So I just wanted to say, I pulled the 10 years, took 2019 versus 2010 pharmacy spend. And if you take the last 9 years of pharmacy spend, it's going to increase a total of 7.3% over 9 years. Which, if you do the data per year, it's 0.01%. So if you're looking at trend rates of 6% every year, we've only increased 7.3% if you take this last year versus 10 years ago.
You've got to. Oh, sorry.
And then if you look at our medical spend, we've only increased 10 million we went from 44 million to 54 million. So if you do I didn't get a chance to do those numbers, but they're a lot less over the 9 years than the 6%. And I think one of the things that there is validity to what's being said is that we are controlling costs, we are doing the right thing, but to start saying that we're going to trend 6% for the next 3 years I don't see that happening. That's all. I just wanted to say that so that everybody knows.
And there is volatility from year to year, so it's not necessarily a constant flow. So what we're looking at is on a year-to-year basis here with the trends. But for 2020, we're providing this first box here, projecting so what we're showing here, we're starting again with the 9.2 million in current fund balance. The projected, it technically is a gain to the first 6 months of the year, but that's strictly due to the influx of the premiums of 5.5 million for the July premiums. Otherwise, that would be a loan. So that is artificially building up this projected fund shortfall here of the 1.16 million compared to the required fund balance from the state of 11.86 million. Again, on a projected basis. So including that trend. 6 months down the road. But then once you incorporate the projected loss for July to December, the projected shortfall at the end of 2020 is almost 11 million at the end of 2020. So that does have a full year of trend certainly built in there, as we talked about, the 6%. So if performance is better than that, then that number will come down. But if it's worse, then it would go up. And then and just want to point out, so the actual, the expected fund balance at that time is still in the positive, but 1.1 million. And then we go through the same process for 2021. I definitely want to caveat, we do not, typically to project 2 years out of trend, that is a lot of trend. So certainly want to caveat that there's a lot of assumption going on there and how claims would rise over 2 years. But the projected shortfall at June 30th is the 12.7 million. But then when we get down to the December of 2021, the shortfall is over 25 million, and actually the expected fund balance becomes negative in 2021 at around 12 million.
Can I ask a question? What's the, so if they find that we're under our fund balance, the state, what, is it a slap on the wrist and then you have a year to fix it? What's the process here when you follow it?
They would typically, if we end with a positive balance this year, which we are projecting, we typically will get a letter, and Amanda can talk about this because she deals with other school districts. We are not unique in this situation. Almost every district out there is going through the same thing, or last year, they had their issue last year. But typically what the state will do is they will issue us a letter saying, what is your plan to correct this, to build back your 60 days? We have to provide them with a plan on what we're going to do to build back that 60 days.
Do they have a projected growth number that the state uses that's different than the 6%? How are they, because we could one year have it, not have it, and the next year not do a thing, and all of a sudden have it because our expenses went.
No, they rely strictly on the numbers based on our actuarial reports submitted.
Right, yeah, it's actuarially certified. They also have actuaries on their side that are verifying that what we are doing is reasonable as well. And certainly we'll ask questions. We definitely have a lot of back and forth, similar to an auditor situation where they're asking questions about how the numbers are developed. So we provide all of that to them. So, we've had clients that have, as Mark said, are still in the positive, but very low. A little less information maybe is required from the state at that point. You do need to provide a plan of how you are going to build it back up. And also you need to provide what your general assets are that are available, that are available to be transferred to the medical plan in the event they are needed. And that's a letter that needs to be signed by the CFO. All parties need to be aware, the board members would need to be aware of the situation and the letter was going out. But then we have had clients that have actually gotten into that negative situation and have been forced to stick to a plan and get that up to that level that's required over time. But
if you recall what I said earlier, back in 13, if you look at the years prior to that, we were getting those letters. And I believe what I recall, and you guys that were here, chime up, because I think for 3 or 4 years we had received those. Judy Preston was the CFO at that time. She was writing a letter saying we have sufficient funds because we have the board's contingency fund to fall back on in the event that we go into the negative. And the state was accepting that, and they accepted it for, I believe, 3 years. Is that correct, Bonnie?
Yeah.
So they accepted those letters for 3 years. On the last year, they said you can no longer do that. You must correct this and have the plan be solvent on its own.
And we
so we have the potential of being able to do that again. As long as I've talked to Amanda and she has indicated, so you clarify if I'm wrong, but she indicated that as long as we end the year in the positive, it's very likely that we could potentially get a letter from the state indicating what is your plan, and as long as it remains positive, they will do that for probably 3 years. On the 4th year, that's when they're going to say, you have to fix this now, or else you can no longer be self-insured.
At least be moving in the right direction. And we have seen, I think the big caveat here is they will potentially, none of this is set in stone. There's nothing from the state that says, here's the outline of exactly the step-by-step what you need to do in this situation. Everyone is on an individual basis. You submit your plan to the state. They may have questions about it. So in our experience, they want you to stay self-funded. They're not trying to force you out of being self-funded, but they're trying to help you get in the right direction and make sure you have a good plan there. But all that to say, it is ultimately they are the ones to approve or not approve. So we can't guarantee that they will approve things, but in our experience, they have been very, very willing to approve your work.
Can I just want to say one more thing? Last April, when we did our request for proposal through the purchasing department, we asked 2 things. We asked, carriers to give us anybody who's doing an administrative services only contract, which is Cigna, Aetna, United Health, and the like. We asked them if they would give us an ASO comparison, which we compared, a PBM comparison, which we sent to others other than just those. And in addition to that, we asked, what would it cost for a fully insured program? Only one of those carriers submitted a fully insured, and it was Cigna, and they wanted $20 million more a year in premium that we're currently charging. So that's one of the benefits of being self-insured, because instead of all that money going out there, you maintain it and control it a little bit better, which is what we've been trying to do, is manage the plan and keep the costs as low as they can. Sure.
Any questions on this page on here? We're very short on time. Okay, I will not go over, this is really a summary of what we just talked about, so I will not go over that unless anyone has a specific question. It really just summarizes the prior chart. And then,
So I've got 10 minutes, so I'm going to ask Chair as far as how would you like, to proceed in this relative to.
Can you cut that down to 5 minutes? and then we will bypass maybe some of the other slides.
I can go through this. So here's kind of when we look at, today we built kind of the where you were, where we're going, or where you were and where you are today. So hopefully you were able to see, benchmarking where you stand. You've been able to see from a pharmacy spend where you stand, medical spend, etc. And so when we look at the different strategies, as I mentioned earlier, there are a couple things that you should look at. As other districts, there's generally a couple other options. So there's choice plans. There's options to go to a closed network. And I'm going to jump around a little bit here, but no out-of-network benefit, we've had districts that have moved to no out-of-network benefit. So on the extreme side, if you were to move to a no out-of-network benefit, that's $1.3 million that could be saved. I'm not saying you go to only a no out-of-network benefit, okay? But there are options depending on how you decide to proceed. Is that an option that we consider along with our current plan? So the 1.3 is real if you move everybody over. The chances of you doing that may not be that great, but it is something to consider. So I'm trying to ask for a little guidance as far as
how much out-of-network utilization is going on right now?
Well, it's 1.3, so you figure 54. It's not much, right? It's 2%, 3%, but still, it's 1.3 million. We're. I think when we look at a solution set here, we've got to put a bunch of nickels together.
Yep.
We're not going to find a silver dollar to solve the problem with one solution set.
How does that work if you're out of town and have an emergency?
Emergency would be covered under that particular component.
As well as urgent.
I'm sorry?
As well as urgent?
Yeah.
Urgent and emergency care.
Emergency would be
They
covered.
just didn't go for treatment outside of Brevard County.
It would be outside of the county area. There'd be no coverage if it's a planned event. And so I think, again, we can tee more of this up at the side.
If I have to have a really highly specialized surgery where I would prefer like the top of notch provider in Orlando to do my heart surgery or something like that, and there's technically a cardiac surgeon here in Brevard, I wouldn't be covered?
Correct. Yeah, it's, as I said, but I need you to understand, there are school districts out there that have these narrow network, I would say alternative networks as well as HMO networks. And they offer the other option to buy up. So if you wanted to buy up and have out-of-network benefits, then that would be your choice. Again, kind of a choice option. The other discussion was really on the potential of SureFit, which is a modified network, as well as potential direct contracting. And I'm going to ask Brian if you can kind of give us an update as far as that option being, continued to be negotiated.
Yeah, we've worked, Ron McCord, actually, our hospital contractor, worked with Chris, I think at Paris, and some other people with Health First, and they're willing to do SureFit. Verbally, they've agreed to do SureFit. Which won't be available, I think, until probably July of 2022. Right. So, in lieu of that, we've talked to them about doing a direct contract between Parish and Health First. say that because she must hear me. That's serious for some reason. But they have agreed to do a lower reimbursement rate for Brevard schools on a client-specific network basis that we can get in place by 1/1/21. It takes about 90 days to implement that. So
I think it's Ron, what was the percentage that both Parish and Health First agreed to if we went to a client-specific network?
Well, that's what we're working on with both of them. Yeah, so we haven't finalized it. Chris has agreed to it. Health First has also agreed in principle, but we're just trying to get to the specifics of it now.
And I would never want to put pressure on Chris, but I understand in years past he said a 10% discount. If we could do something like that at Health First, that's what we're talking about with these potential savings that are listed in this policy.
You would probably need, I think, more than a 10% discount, Mark, because there's going to be some leakage to the extent where you have a heart attack over at Disney, right, and end up at Celebration. But those are things we need to work out to where we would hope to get overall that 10% reduction in your claims costs.
We have a
for that narrow network.
Yeah, we have a SureFit network now at Orlando with Advent Health, so what we're talking about is expanding it over here and then also the pollution. So here it would be Health First and Parish.
And when are you projecting SureFit will be in Brevard County?
That's
2022.
July of 2021. That's what we're looking at, roughly.
Would it include?
So in the interim, what they're
For
saying,
us,
right.
It depends.
because I'm thinking of people that have a premature baby that go to Winnie or to Advent or something like that, so we just don't have it in Brevard County. It's
Yeah,
just
it
not-
wouldn't be for everybody. You would want to offer this alongside your other plan.
Yep.
To Jonathan's option, you wouldn't maybe buy into the plan if you want to. But for people who are younger, 25-year-old teachers that are healthy, they want maybe a low-cost option or a zero-cost option, like some school boards do, that's a good option to consider.
And once it's set up, you could go to Orlando. It would just have to be Advent Health. It couldn't be Orlando Health rates.
Couldn't go to Orlando and that's true, right?
Yeah.
So you guys have reached
Because the
out.
Health First Network has all the Advent Baptist hospitals
Right, so
over in
yeah,
Orlando.
that's what
So
I asked,
if
would
it's a
Advent be
direct
part of that,
contract
because
there,
they could cover the
who knows what that
preemies
will
and
look
women's
like.
health and things like that.
You guys have reached out to both Health First and to Parish,
Yes.
and you're saying that in order for that conversation to create a direct network, it's going to take 90 days?
It'll take 9 days for us to implement it correctly into our system by 1/1/21.
Just to load it into the.
Yeah, so we need to know by
system.
September 30th that it's done. That's exactly what.
So if we wanted to move to a direct network with them currently, walk me through that process. So for 2020, we want a direct network through Health First and Parish, or vice versa, or wherever that is. Walk me through how that happens.
Well, I think the parties meet and agree to a contract reduction to your current reimbursement rates with Cigna by X%. All parties sign the contract that we all agree to, then Cigna loads that into the system. And for those people in that network, we point them to, in our system, to that network. We give them a new network ID number. They would then be pointed to in our system, for lack of a better term, and then we pay the lower contracted rate.
And that is possible to do this year if the board directs to do that, to create an alternative network through those two organizations for 2020.
For 1/1/21.
21.
But you could do it for 2021, sorry.
Yes, 1/1/21, correct.
It'd be perfect for open enrollment.
We would have, I need to caution everybody, every plan every change we have has to be bargained with our unions. But we
School
have that
districts
potential.
have that in their contract. Does anybody know if that a common practice or are we some low?
What is your question? I'm sorry.
How many school districts have their,
Dr. Theddy, do you know?
so much of their medical in their contract? It seems absurd to me.
It's a mandatory subject of bargaining health insurance, and we plan on continuing to bargain health insurance.
I think on that, we just need to make sure that the taxpayer has a voice in this. So if there's a way to save money with a lower cost narrow network option or renegotiated contract, just put them side by side where the costs are, let the taxpayer see this is what was offered, this is what was rejected, and they're going to vote on, excuse me, Matt and I were talking about the millage increase, things of that nature. So if you put the facts on the table, here's a reasonable health plan, narrow network option, here's the existing plan with higher benefits, you really just have to take one or the other.
Dominic, so, the thing with the narrow network, it's an interesting idea, but, one of the things I asked Mark to address at this meeting or someone was, like, okay, I don't even know how much it would cost to go to the doctor without health insurance. I mean, some folks might know, but I don't know. Or with this, limited health insurance I'm paying out of pocket. I don't know how much it even costs to go to the doctor. We don't have a narrow network in place. We know that our education piece is not what it needs to be. They don't really understand the one plan that we have. And so I'm not saying no, but I'm just saying there's not a lot of information we have. And then we're talking about these health savings accounts and so on. I mean, we would need a lot more information to be able to consider something like that.
I think, but what I do think is that if we continue down the road we're going down with no other options available to the plan, that would be the wrong message to send to everybody, right? So in the event that there is something that we need to do, we just need to figure it out and make the right decision based upon the data that we see. So, but going through the plan and doing absolutely nothing to it, I don't think is the way there.
Two questions about that narrow network. Do we keep the health?
Alternative network? Can we just
Two questions about the alternative network. One, do you keep the health clinics? Is that part of the solution? And two, do our employees that aren't using health clinics get to keep their doctors? Or are we now so narrow that...
These are all questions.
And I mean, do we actually...
You're going to get down in the weeds right now, I think.
But do we actually know what the savings are on the narrow networks? I mean,
10%.
20%?
10%. They put that on the table.
Of what?
Of the overall spend.
Okay.
And that's not just based on further discounts from the hospital. We're really looking at more value-based. So, CARE says a clinically integrated network. Health First is building that, so they're going to really manage the care of the patients better than just cutting the rates. And that's part of it.
And also look at the way you utilize healthcare. Most people go to a local doctor. Okay, so a narrow network is probably not going to impact them that much. We saw the slides in the previous presentations last month. 87% have less than $5,000 in medical claims. 90% generic utilization. Those people would actually benefit from a narrow network if it was priced right.
Right.
If we could save you some money. That's every month when you pay a health insurance premium, that money's gone whether you use the plan or not. Okay? If we could provide some savings for you where you kept some of that money in your pocket, then hey, you manage your health care in the narrow network, keep control of your money, it's probably better off for that 87% of the population. But we do have to price it right. You can't undercut the overall plan.
Well,
right?
I think we have to study really carefully too. It's not the general practitioner that is the concern. It's when you get into specialists and very exclusive specialists, like a child with diabetes. There is one pediatric endocrinologist in this county, and he's booked solid. So a lot of my peers that have diabetic children have to go to Nemours. That's the closest one. They have to go into Orange County to see a pediatric endocrinologist. If we narrow that network down and say, this doctor in Melbourne's the only one, and you can't get in because he's booked out 8, 10, 12 months.
Yeah, so I
Then
think
we've got to
there's
fix
a
those problems.
there's
a happy medium.
That's why we're offering multiple choices, because it won't be.
The narrow network's going to have to be bigger than Brevard County.
So let me just say, there's going to be
Network is
follow-up,
bigger
if I
than
can, because I want to be careful of the time, I know. We've got to follow up on the network contract for it to be completed. And the 10% that we recognize is based on distribution and based on where people fall. There's multiple components to that. So our objective would be to bring it back to the Siac committee, make sure that you all take a look at the geo access as well as the numbers that we can come up with to address some savings and some options. Because there's got to be some changes. There's some drastic changes that can be made, but that's going to impact the membership as well. And I can go through the rest of this. I just don't know what my options are at this point.
Yeah, I'm actually, just to be respectful of everyone's time, we did tell them that we would run until 3 today. So I think there's been a lot of discussion about kind of some additional data that various people have requested. And I think obviously there needs to be additional details on some of the recommendations in order. I don't think there was an intent for us to come here today and make a decision as to how to move forward. It was to give us preliminary information for us to be able to identify what additional information we need. For the board members, I would recommend that you reach out to Dr. Mullins and let him know what additional information you would like to get if you did not voice it here today. Anything that you would like for him to look into to bring back to us. And then obviously, the Siac committee, you all have your plans going forward as well for additional information, I think.
Can I give one bit of additional information real quick, sorry? Just last time there was a premium increase. It increased for the employee $35 a month. Didn't matter which plan you were on, it was $35 increase, and the board increased their contribution $70 a month. That would generate $8 million. We replicated that.
Thank you.
Just saying.
That's a good point.
So just from a direction standpoint, from our standpoint, and Anthony, this would be helpful, that we come up with different kind of designs and contributions. I think that was our biggest question coming out of this. Can we come up with some different designs and contribution based on the direct contracting and based on, other components to present to you and the Siac committee? Dr. Mullins, is that okay if we wanted to just put some options out there, because with this one option, there's some draconian options as you've seen.
I think there's, in my collection of the conversation around the tables, there's enough interest in alternative options that Siac wants to look at and give us consideration. As we move forward, I would direct you to absolutely work in that direction and bring all options and spectrums to the table and what the potential impacts would be.
Perfect. Well, we appreciate that.
Can I ask, we were talking about auditing the pharmacy, right? Can somebody walk me through the audit of the pharmacy, how that's supposed to happen, who's actually going to do it, what deliverables, what dates, that kind of stuff? Because it's one of the...
Yeah, if you want to do that right now, or you want to do it off-site, or just, let everybody go. Phil's here to talk to you. I don't know how you want to handle that. We'll handle it whichever way you prefer.
I mean, okay, can we actually lay out a timeline about all of these things? Meaning, right now we have a decision to make within a certain number of days. What with being on the chair, being on this thing for as long as we have, we've been in these meetings where all of a sudden they come back and then we never make any changes because the time runs out, right? So can we lay out, okay, it's February, we're going to come back with plans in another meeting in X, make a decision by Y for the next plan. Does that make sense to you? Because we're individually going to go to Dr. Mullins and say, hey, this is what I want, this is what I want, this is what I want. That's somehow going to filter down to these guys who are then going to come back with something, right? But we need to have some kind of time certain to do all this, because he's saying 90 days. So if we do it from now, and we gave him the direction to do it, it's not going to be until June, July that we can even do it.
No, he said he had to know by September 30th to make it effective January 1st.
To load it into the system.
But we haven't even given him direction over exactly what we want.
No, but to your point, we need a signed contract in probably April. For you, depending on your timeline going backwards to the board.
So he's saying that by April, we have to have given direction over what we want to do.
Yeah.
Then he has to go out, bring that back to us, and we have to make a decision. And that's within 60 days.
And then you have to negotiate it.
And then we have to negotiate it.
That's the other negotiation.
It's a lot.
It's a lot.
Well, and that's why, going back to my original thing, do we want to try to solve the whole problem this year or just get through another year with some improvements?
I think to your point, Anthony, one of the issues that we seem to continually run into with regard to the changes in medical is I think we're going to have to look long term is my short answer to that, because what we run into is being able to make changes in a timely manner and having time to bargain the changes. It is just oftentimes not feasible. So, I would suggest that we're absolutely going to have to look both at short-term and long-term solutions to move forward. For me, Mr. Susan, I have a ton of questions and requests for additional information that came out of today that I think that we need to look at. I think that education is a big piece of it. I don't know, Mr. McAlpine has shared with me multiple times how he has worked with unions and other places to really build that education piece, which I think is key. Making sure that our employees understand how their health decisions impact their costs. I think there's a lot of opportunity there. So I think there are some things that we can do that can have immediate impact, and there are some things that we can do that are going to require changes. If you would like to set to touch base with Dr. Mullins 30 days from now and have him get back to us, or 2 weeks from now with all of the information,
I was just looking at it, and if it's February 18th, we go 2 weeks, we're in March already, right? And then that only gives us 30 days to RFI, get the information and stuff like that to April, and it's already
we're running out of time.
Right. So what would you like to do?
If I could make a recommendation, I think that we need to come back together sometime in April or May as a group, as a Siac, to discuss all of the options on the table together, rather than behind the scenes, and it's up to him, Aeon going out. Am I on pace? for
Well,
the right thing?
I think if we're communicating openly, that's always the better plan.
So is that saying that you would like to come back in April with some of the design plans and stuff like that for
And-
decision, so they can move on whatever the right
Yeah,
thing is?
yes.
Okay. So
Well, but
maybe-
you need to say SIAC's gonna get this in March, right? You're talking about getting this
Well,
together possibly in March or no?
Well, I mean, there's a lot of,
There's a
we
lot
have
of
to be
moving
defined
pieces.
what that is.
There's a lot of moving pieces.
I think we would help to give you a little narrower direction.
Yeah.
Alternative
that's what we were doing.
directions,
I know-
that's
I know-
alternative
I
directions.
thought that we were supposed to give a little bit
But
more,
we
these
can-
are the three options.
We can work with Mark and come up with the follow-up information and get it to Dr.
Well, I
Mullins.
mean, let me just say this, right? So one thing that I don't have the stomach for is like a massive premium increase for a family plan versus an individual plan. With me saying that, I mean, should we continue to waste our time looking at that option?
Right.
You know, just being honest.
Right.
And
SIAC meets in March together, right? Can we tentatively say we might come back in April so that we can have a group discussion over some of the issues that have been out there for a possible decision? Because I have a lot of follow-up to it.
Yes, the one thing that I need to look at, and I will go back and look at specific policy, is how much the board direction and the SIAC committee direction weigh in on, obviously we have to approve what comes forward, but I just
Yeah.
want to make sure that we as board members are not overstepping our role in driving the decision-making on that aspect. So if we want to tentatively plan to come back together in April and we can start looking at some dates, I think that's fine.
Normally, the process would be SIAC makes a recommendation to Dr. Mullins, then they come back to us with that. The problem is that due to the time constraints, we're going to kind of shrink those two by being together. That's
And those time constraints are to hit some of these options as soon as they're available. They could start later, correct?
Yes.
Okay. But of course, we want to fix the problem as soon as possible.
Well, yeah, some of it will be based on, hypotheticals, which isn't a fun conversation, but you have to, if that's what we have to have, we'll have that.
We've got a July 1 that we have to deal with, and then ideally on some of the longer term, short-term, long-term, for open enrollment, which kicks off in October for a 1/1 effective date. So that's a lot of moving parts for both Aon and Cigna and everybody else.
Yeah, well, I appreciate that Mr. Susan's at least trying to keep us moving forward. It's tough sometimes.
Absolutely.
All right, thank you, Jonathan.
Okay, thank you.
I think we will suspend with the rest of the program, and I'll turn it back over to Mrs. Miller.
Thank you, Mr. Langberg. And Mr. Susan, Dr. Mullins and I were just speaking, he is going to be there at the March SIAC meeting so that he can be a part of that discussion. Remembering that he actually has to make a recommendation to go to the board, so.
Or no, should be. Okay. As long as we make them know that we have to make a decision, we can all start wrapping our heads around that and try to start driving all conversations with that.
Absolutely. And for board members, if you have additional requests for data based on our discussion in today's meeting, if you would please let Dr. Mullins know as soon as possible so we can share that with Mr. Langdorf to get that information, okay? There being no further business, this meeting is now adjourned. Have a great afternoon and thank you all.
My son's right down the street. He's asking, we got a presentation.